evening to one and all present here. I welcome you all for today's webinar on breast cancer management 2022 and beyond. With immense pleasure, I would like to invite Dr. Vijay Agarwal, who is lead and senior consultant medical oncology and hematology, Esther CMI, Bangalore, for the welcome and introductory note. Over to you, sir.
Thank you very much. And I think I would like to welcome each and every one who's here this evening for this exciting information overload on the treatment of early breast cancer for 2022 and beyond. I think a lot has been changing over the past few years, and pretty much with every ESMO or ASCO meeting, new information comes out, and it's quite important that we meet together to understand how to assimilate these information in our practice. And this evening we have an exciting topics, right, ranging from the role of comprehensive genomic profiling to the role of immunotherapy and specific molecular testing, such as how do we assimilate things like PIK3CA and ESR1 mutation in our practice. So I think I will hand over to the speakers without wasting much time. But please, thank you all for coming and welcome all. So the first session will be by Dr. Amit Verma on the role of comprehensive genomic profiling. So please carry on before wasting any more time.
So our first session is sponsored by our academic partner, Roche Foundation. And for this, I would like to invite Dr. Amit Verma, who is MD AIMS founder and director, Dr. AV Institute Personalized Cancer Therapy and Research, Gurgaon. Over to you, sir.
Dr. Amit, you'll have to unmute yourself.
Can you hear me now?
Yes, sir.
All right. So I just was thanking all the organizers, including Dr. Murli and Dr. Vijay and Dr. Sood and the Roche Foundation to give me this opportunity to share my thoughts on this topic. So I will be talking on the topic of comprehensive genomic profiling in breast cancer. And these are the disclaimers. So we all understand the basics and nothing much to talk about, but triple negative subtype of breast cancers are the notorious one. And we are trying to look for some actionable targets in triple negative. So this is the bottom line. And we also understand that even the HER2 positive disease, whenever we give hormonal treatment, they tend to fail eventually. And there are various resistance mechanisms which we need to understand and do some modifications in the treatment so that the patient can benefit. And similarly, the HER2 positive disease, not all HER2 positive disease responds in the same way with the anti-HER2 therapy. So this comprehensive genomic profiling is going to help us understand this current subtype of breast cancers into more depth. So what we used to talk about earlier has now changed into the pathways driven breast cancer subtypes. Here on the right, you can see that we are trying to understand and decipher what dominant pathway plays a role in this breast cancer subtype, whether it is PIK3CA alteration or DNA repair alterations, or ER signaling, or cell cycle dysregulation, or a pathway which is growth receptor dependent. So why we want to do the comprehensive genome profiling is a big question. Whenever we try to do, we see some lot of alterations, and this is a long tail plot for both all of the subtypes, that is ER positive, HER2 positive, and triple negative. And you can see among all the alterations you are seeing here in these different subtypes, PIK3CA alteration seems to be dominating in the majority of them. And similarly, other pathways are also observed, including ESR1 or PTEN. And similarly, you have some targets like PIK3CA, PTEN, and like CDKN2A and FGFR1 and F1 as well. So you have multiple actionable targets which can be picked up when you do comprehensive genomic profiling beyond the standard treatment. And the comprehensive genomic profiling not only pick up the point alterations or short variants, what we call, but it can also pick up rearrangements like you can see in CDK12, where the rearrangement has been picked up, or copy number alterations at the same time. So the comprehensive genome profiling offered by Foundation Medicine have the potential to pick up alterations which have therapeutic as well as prognostic significance. We all understand the importance of HER2/neu amplification, which can be picked up by CGP, that is a comprehensive genome profiling. But in addition to HER2/neu amplification, we can also identify short variants, and these short variants again are targetable. So similarly, BRCA1, BRCA2, PIK3CA, PTEN, mTOR, AKT, FGFR1, FGFR2. These are the major actionable targets which we can identify when we do the comprehensive genome profiling. Along with the predictive biomarkers, we do have some biomarkers of prognostic significance like TP53, ESR1, NF1, RB1, and HER2 itself. So if we try to summate these alterations into different pathways, we will find that majority of the breast cancers predominantly show the activation or dependence on the PIK3 AKT mTOR pathway, followed by the FGFR and the CDK pathway. So you can imagine these three pathways are all actionable. Then we have pathways which are affecting the HRD, and then we have the HER2 signaling pathway, including HER2 and HER3 alterations as well, which are again actionable. It can also pick up pathways where hormone resistance can be also predicted. So in a nutshell, this information is very, very crucial for us to take the next steps when the first line or second line treatment fails. Not only it can pick up the common alterations, but the rare alterations, which are tissue agnostic like NTRK, RET, and BRAF can be easily picked up by the CGP in breast cancer. But are these alterations important? Let us see the BRAF for a second. BRAF is seen to be present ER positive, HER2 positive, and triple negative. If you combine them together, it is 7% in total. 7% of the patient, all breast cancer taken together, is a big number for us to identify. So if you do not do the CGP, you are missing the big chunk of it. Similarly, the MET alterations can be picked up in the range of more than 2%. Even rare alterations like KIT, approximately 5%, and EGFR in the range of 9% taken together. But if you see the triple negative alone, where we are looking for actionable target, these all rare alterations are quite high in number. So again, giving the hopes for many of the patients where we are struggling with treatment options. So there are a lot of strong rationales for assessing and targeting several major breast cancer related alterations, especially the PIK3CA alteration, which is the commonest. So PIK3CA pathways alterations, which includes majority of the proteins involved in the pathway, including PIK3CA, PTEN, PIK3C2B, and similarly, you can see almost 10 different alterations which are being picked up, suggest that the patient is having the PIK3CA pathway dependency, and PIK3CA inhibitors can be applied in this scenario. Along with that, HER2/neu short variants, which are the alterations beyond amplifications, can also be targeted in anti-HER2/neu therapies, and BRCA alterations, which we are all familiar, where the germline alterations or the somatic alterations which are present in the tumor testing can be picked up. Similarly, ESR1 alterations can be picked up in hormone-positive cancer cases, and as we understand, on the treatment pressure, the ESR1 alterations are evolved, and clonal evolution does happen. And we need to be more focused at the later lines to identify the ESR1 alterations. So let us talk about some evidences. So this is two important trials which I wanted to emphasize, the LOTUS and the PACT, where they have investigated the AKT target therapies in triple negative breast cancer. These two important trials are not selected on biomarkers, but they have done the comprehensive genomic profiling as a retrospective way to assess the subset analysis. And what they found that if you do not do any analysis or subset division, even if you do not do that, the AKT target therapy can prolong survival in triple negative breast cancer. Both the PFS and the OS in LOTUS, PFS and the OS in PACT can be seen to have a significant value. And you can see the separation of curve. The PFS benefit is 4.9 to 6.2, and the OS benefit is 18.4 to 23.1. It is a non-selected way of triple negative in applying AKT target therapies. And the target therapies were ipatasertib and capivasertib. So if we do the enrichment of the or the cases where the PIK3CA alterations and AKT alterations or PTEN alterations were evaluated, so the separation of the curve was far more, 3.7 versus 9.3, almost just 3 times the PFS benefit when you use capivasertib with paclitaxel in scenarios when we know that the PIK3CA pathway is altered in triple negative breast cancer. And this was also translated into OS benefit. And it was the OS, the median OS was not achieved for the patients who were having these alterations as compared to 10.4 months in the one which were wild type. So similarly, in the LOTUS also, the separation of the curve in the PFS was observed, which was significant, and similarly in the OS benefit. So there is another study called EPAT Unity 130, which tried to build up on the LOTUS finding, and they can not only involve the triple negative cases, but also hormone positive cases carrying the PIK3CA alterations or AKT alterations or PTEN alterations, and using capivasertib plus paclitaxel. And what they found that there was the separation of curve, and right now the recruitment is going for this. The data is not available, but this seems to be something for the future to be discussed. But I'm very hopeful that you will find important findings very soon. So similarly, we all understand the SOLAR-1 trial where PIK3CA selection have shown in hormone positive cases that when you combine with alpelisib PIK3CA inhibitor with fulvestrant, there is separation of curve both for PFS in the PFS arm, and this is something very important. And you will not see these benefits in the PIK3CA wild type cohort. So identifying the PIK3CA alterations can only happen when you do CGP. And why? Because PIK3CA pathway, if I go back and just talk about this particular graph, beyond the single testing of PIK3CA, there are various other alterations which can be reflected on the PIK3CA pathway dependency and can be only assessed by the using of CGP. So having said that, this CGP is quite robust in terms of that it has a lot of concordance with the IHC and FISH, especially for the HER2 amplification, with a concordance of 98% and 99% in subset analysis. And besides the HER2 amplification concordance, it can also pick up the HER2 and HER3 alterations, which can be targeted by a pan-HER inhibitor, that is neratinib. And here, this is a data which talks about that HER2 short variants are seen in 3% of ER positive cases and 7% of HER2 amplified cases. So imagine that you can use some better drugs whenever you encounter some challenges, even in both the cases, that is ER positive and HER2 positive cases actually. So besides this, the CGP can pick up the germline and the somatic BRCA, that is what we call as tumor BRCA, in all the subtypes, whether it is triple negative, hormone positive, or HER2 positive, and again, making the patient eligible for PARP therapies. So now the next important pathway which is observed, which causes hormone resistance, is known to cause hormone resistance, is FGFR pathway. And FGFR fusions are well reported in cholangiocarcinomas and bladder cancer, but in breast cancer, we tend to see amplifications, not fusions. So these amplifications can be picked up by the CGP. And this is a important drug, ducitanib, which is in the endovitinib. When it was combined with fulvestrant, you can see that the hazard ratio is 0.64, and the benefit is observed when you use FGFR inhibitor with the hormonal agent. And right now, there are other drugs like infigratinib, which is under investigation as of now. But having said that, FGFR inhibitor is going to come up, and there are various important scenarios where you would love to use the FGFR inhibitors, especially in the scenario of the hormone resistance. So besides the predictive benefit, I would like to talk about the prognostic benefit. TP53, we all understand, carries poor prognosis. And here you can see the hazard ratio of 2.20. Similarly, RB1 alterations have poor prognosis, and the NF1 altered patients have poor outcomes. Along with this information, RB1 can give you the mechanism of resistance to CDK4/6 inhibitors, which we all understand. That's an additional information. And NF1 alteration can predict the resistance to endocrine therapies and anti-HER2 therapies. So interestingly, before investing a lot of monies in CDK4/6 inhibitors or anti-HER2 therapies, these two important biomarkers can tell us that would you get the de novo resistance, or would you get some acquired resistance during the course of treatment. So ESR1 mutation may also help to drive the choice of endocrine therapies, and we know that they are the mechanism of resistance to hormone therapy, and fulvestrant is a choice of treatment in these cases. So I will just quickly summarize two important cases, and then we'll just hand over back to the organizers. And this is an interesting case where the CGP identifies BRCA2 alterations in a metastatic breast cancer case. And this is a hormone positive case which received almost 8 lines of different therapies, and patient underwent foundation test which found to have BRCA2 alterations, and the patient was given PARP inhibitor with Lapodox and followed by olaparib. And patient initially showed response. This is a baseline, and then very good response in 2 months, and then at 10 months there was reappearance of the tumor at the same site, and a repeat foundation was done with both at the liquid biopsy, that is the foundation NAC, and the solid biopsy, that is the foundation 1, both with BRCA2 reversion mutation, which can explain the resistance to the PARP inhibitor. A second case, a triple negative breast cancer case with BRCA1 mutation. Again, this patient progressed on the standard lines of chemotherapy, received olaparib, had good control in both the brain as well as systemic disease. So having said that, the key messages, because of the paucity of time, I'm rushing around, that CGP could potentially help in identifying actionable targets, improving in prognostication and identifying patients at high risk of resistance, and also disease monitoring and target therapy allocation through liquid biopsies, with application for both ctDNA detection and sequencing. So with that, I thank you for your kind attention, and over to the organizers.
Thank you, sir. Thank you so much for your excellent talk. And any questions which need to be addressed by the doctor? If there are no questions, then we will move forward for the next talk on neoadjuvant. And for this, I would like to invite Dr. Vikas Talreja, who is Senior Consultant Medical Oncology, Regency Hospital, Kanpur, and he's going to speak on role of IO chemo in neoadjuvant triple negative breast cancer. Over to you, sir. Vikas, sir, can you hear us? Yeah. Good evening, sir. So we cannot hear you.
Dr. Vikas still not audible.
So,
Thank you, Dr. Amit. Lovely presentation.
Thank you. My pleasure.
I'm audible now?
yes, sir.
Perfect. So can you share my slide sets? Thank you, organizers, for a beautifully crafted agenda. Thank you, Dr. Rahul Sood, personally for invitation, and thank you, Dr. um, Amit, for a beautiful presentation. We would be doing immune check-in point inhibitors in early triple negative breast cancers, and we know. Can you share the slide set on my behalf?
Sir, have you shared your slides with Mahima?
Yeah, I mailed it many, I believe, on 10 days back.
One second.
Are they available, or I should be sharing it from my behalf then?
Sir, is it? I need to check, sir.
So
If
it's
it is
kind of you if you share it from your end to avoid
Yeah.
the.
Perfect. So give me a second.
Sure.
I hope it is visible now.
Yes, sir.
Perfect.
It's moving. Yeah.
So TNBC, as we know, is responsive to neoadjuvant chemotherapies with outcomes similar to the non-new triple negative breast cancers, and the therapy options in triple negative breast cancers which have improved outcomes. We know that with neoadjuvant therapy, when we try to downstage the tumors, we allow additional time for the germline mutation testing. The neoadjuvant approaches to increase the pathological complete response has been platinum, sacituzumab, Covinten. We have tried implementing checkpoint inhibitors in a lot of these approaches to increase the pathological complete response. And even if we can't alter the biology in the neoadjuvant situation, we try to alter in the adjuvant situation with the adjuvant capecitabine and the olaparib. And that's where we have seen this residual cancer burden has an impact on the overall survival and also the disease-free event survival for these patients. And therefore, immunotherapy in breast cancers, early stage versus metastatic breast cancers, we know that in early stage, as we know, there is increased tumor antigen presentation as compared to metastatic breast cancer, where the antigen presentation is reduced. The tumor clonality is much less in early breast cancers as compared to in metastatic breast cancers. The intratumoral heterogeneity is much reduced in the early breast cancers as compared to the metastatic breast cancers. The tumor infiltrating lymphocytes, the CD8 plus T cells and the dendritic cells, these are much more in the early breast cancers as in metastatic breast cancers. The PD-L1 positivity is much higher in early breast cancers as compared to the metastatic breast cancers. The chemoattractants and the interferon signalings are much more higher in early breast cancers as compared to metastatic breast cancers. So that's what's the rationale for putting up immunotherapy early in your outcomes. And it has been beautifully demonstrated in a Keynote 522 trial where the new adjuvant pembrolizumab or placebo was added with the chemotherapy followed by the adjuvant pembrolizumab. So the regimen was very simple. The Texans platinum regimens in the new adjuvant along with the the anthracycline cyclophosphamide combination followed by pembrolizumab or placebo. The primary endpoint was the pathological complete response. The secondary endpoints was the pathological complete response by the independent review committee, as well as the overall survival and the safety and the overall safety. If we look at the biology of these patients, it was 52% were lymph node positive, triple negative breast cancers, ECOG fit, stage 2 being predominantly 75% and stage 3 being the 25% and premenopausal with 56%. And if you look at the interim analysis, you could look at the events, you could see 6.3% increase in the distance relapse-free survival from 87% to 80%. The hazard ratio being 0.6, meaning 40% reduced chances of events as compared to not giving immunotherapy in early situations. So if you look at the median follow-up of around 40 months, you could see at 3-year benchmark, 76% had some events with the um, uh, with the chemo alone as compared to addition of the immuno alone. Now, if we look at the pathological complete response, yes, there was a difference in those who had a pathological complete response in terms of the event-free survival as compared to those who didn't have a pathological complete response, making it a surrogate marker for it. And if you look at the residual cancer burden also of and the event-free survival after the neoadjuvant adjuvant therapy in triple negative breast cancers, you look at the response rate and the pathological complete response rate, and there was a decreased reduced residual cancer burden as compared to it. So if you look across the trials, we don't have only just a Keynote 522, we have a I-SPY 2 trial, an Impassion 31 trial, a new TRIP-A trial, and a Japan Nuevo trial, where all sorts of immunotherapies have been used. So I-SPY 2 used the pembro cycles, 4 cycles, and you could look at the pathological complete response rate increased from 22% to 60%. The Keynote 522, where the pembro was added in neoadjuvant and adjuvant, again 64% was a pathological complete response rate, and 3-year event-free survival significantly improved. In the NeoTRIP PDL1 trial, where the ATZ was used, no anthracyclines was used, and you could see those were the similar pathological complete response rates. And in the JAPAR trial, where the durvalumab was given, again, you could see a 3-year event-free survival rate improving from 77 to 86%. And predominantly, it was a stage 2-day disease. Now, if you look at the immune-mediated adverse events, it is something which we have been handling with in a metastatic situation, quite common, and you could see not much more incremental benefit as compared incremental adverse events as compared to giving chemo alone. So the CreateX, which we all know, was the capecitabine in the adjuvant situation. And if you look at the magnitude of benefit, yes, there was a difference in the benefit for the same. The safety of the capecitabine and combination of the immunotherapy. So that's the Keynote 62 trial, where the pembro and the chemo was combined, and you could look at from there the safety. It could be easily combined with it without causing much more incremental side effects. We have an adjuvant olaparib also in those patients where we miss the bus in the early situations in the triple negative breast cancer group, as giving in those which are BRCA mutation positive, or an adjuvant olaparib 300 milligram twice daily for an year. And you could look at the incremental benefit of around 9% with a significant hazard ratio of 0.58, meaning a 42% reduced chances of death when you give this drug. So if we look at the whole paradigm of the triple negative breast cancers, we see the whole paradigm is now shifting towards more and more biologicals right now in neoadjuvant adjuvant situations. If the neoadjuvant we give in early stages, whether it's T1C, T1 or more than 2 centimeters or any node positive, you can combine the pembrolizumab with the chemo combinations, go for the surgery. If the pathological complete response is there, you can complete 1 year of pembrolizumab. If there is no pathological complete response and there is a BRCA mutation positive, you could go for the olaparib for 1 year. If it is BRCA mutation wild type, capecitabine 8 cycles. Now, in those which are BRCA mutation positive, the 1 year 9 cycles of pembrolizumab is somewhere which we don't know, and ongoing trials are there to tailor our neoadjuvant therapy to response, to optimize post-neoadjuvant therapies, and to put checkpoint inhibitors in the BRCA mutation wild in mutated populations. And in also the BRCA mutations, will the addition of the checkpoint inhibitors in the neoadjuvant situations with the PARP inhibitors are going to make any difference? That's going to be there. So there are a lot of clinical questions that remains to be answered for an early stage TNBCs. And the more questions we ask, there than the answers that are available. So does neoadjuvant chemotherapy benefit all? We need to carefully bioselect the biomarkers that are there. We need to balance the risk as well as cost, as who will benefit alone from the chemotherapies and who will have that marginal benefit of extra addition of the immunotherapies, and also to whom we can avoid the immunotherapies with ease. And immunotherapies and PARP inhibitors combinations in the adjuvant and neoadjuvant for those achieving pathological complete response or non-pathological complete response, again, is a question that needs to be answered. What chemotherapy backbone? We know that platinums have improved the pathological complete response rate, but yes, the survival benefit so far has not been shown. The CALGB 406303 and brightness trial were very encouraging for the pathological complete response, but then overall response rate, overall survival is what directs our therapy. And so far the platinums haven't shown that thing. Now we have sexituzumab goventen and trastuzumab deruxtecan again coming very good in the metastatic breast cancers. Neoadjuvant and adjuvant, they are the waters that to be tested, and post neoadjuvant again, how we are going to change. We are going to give olaparib, we are going to give pembrolizumab, or we are going to give capecitabine. These questions need to be answered. So these things we need to discuss in patients and also in the tumor boards and in our curriculum. Thank you for patient listening, and over to the organizers for the next. Would love to answer any questions if there are any.
Thank you, Vikas, sir. Thank you so much for the wonderful talk. And any questions from the panelists or the attendees can also ask the question in the question answer section or the chat box. There is a complete silence, so no one wants to ask.
Have you started using Pembro in a neoadjuvant setting based on the landmark trial Keynote 522?
Wouldn't
Because
you?
there's a 7% improvement in at the end of 3 years, and that is significant. Hopefully, when you are early endpoint, you might have a OS, maybe, but that is speculation.
Then again, sir, this was a trial which was designed for. We have seen that pathological complete response is not a surrogate marker for an overall
It had
response.
2 primary endpoints, if you remember. It was pathological CR also. There was not a OS. It was an event-free that was a primary endpoint. And in the 3 year, it has satisfied both the primary endpoint. In fact, OS is not a primary. It is a secondary endpoint in a neoadjuvant Pembro study.
But then again, sir, I would say that considering putting up into the clinical trial and putting up into the real practice is also always different, because you need more experience out of it. And we have seen that many times we change our practice based on something, and then the final overall survival or a long-term results come out to be different. So I would be waiting and holding my horses. I know neoadjuvant triple negative is one of the worst biology to deal with, but at the end of the day, not many drugs work, and we don't know which set of patients will benefit only from the chemos and which set of patients will benefit from the chemo and IO combination. So putting all horses in upfront and putting up to, because at the end of the day, we want the patient to go into the OTs and we want the patients to get the surgery done. So possibly that's
Right.
also very important landmark for us. I would be reserving my Pembros for those who haven't achieved pathological complete response, and then adding capecitabine with Pembro, I would be saying if they are BRCA mutation wild type, so and a strong PD-L1 positive type. So that's where I would right now put, because it's a very incremental cost benefit as we compare to the other subset right now we have.
Last question I'll put it. 50% will not have a pathological CR. So anyway, you will be adding that. My question is, suppose you you have started with Pembro, attained a pathological CR. Should you, again, that is a controversial thing. If you look into that long-term data, those with a chemo arm also who attained a pathological CR and with the Pembro, the 3-year event-free survival was more or less equal. Or so do you think you should really, because of cost constraint, may avoid giving a Pembro if you have achieved a pathological CR? Because the difference with the other arm was not significant in those who had either of the arm who had attained a pathological CR. 8 sizes, finish. If there is a pathological CR, you avoid it. Maybe if it is not, then you continue. Or if it is BRCA, you can add on that. If it is not BRCA, you can add on create. Just
very engaging question, I would say, because yes, I'm a fan of a person. I do a lot of low dose immunos. I believe in the rationality that the immunos do modulate your biology of the tumors, because that's how they work. So I am not somewhere where you need to give a long 1 year or 2 years of immunos. Even if those 2 cycles or 3 cycles of Pembro, if they work, I believe they change the biology, and that's where I believe it's a margin. But then again, to choose the right patient where the chemo and the IO would work together to get that pathological complete response, I would say that's the question you need to ask for us.
Bharat Sahu here.
Yes, sir.
Yeah, so I think I partially agree with Bharat here. I would be offering triple negative if more than 2 centimeters. I would not shy away from offering immunotherapy. The question is, will I add carboplatin? Although the landmark Pembro trial did add, but there are trials to show that carboplatin is not very essential at this point of time, and there has been positive trials with that also, without that also. So the point is, I would probably add a taxane, Pembro, or a immunotherapy as required, and then if there's a PathCR, would then de-escalate or escalate, because the maximum benefit of the adjuvant Pembro actually happened for those who did not achieve a PathCR. The RCB2s were the persons who actually did the best with the adjuvant Pembros. So I think we at this point the data does encourage us to discuss this with the patient, and that should be done. At least we should not devoid those patients of that option at least. And if the affordable patient comes in, why not offer them? And if they can achieve that extra benefit, and triple negative, all of us know are bad. And if they do not achieve a PathCR, we can add what as Vikas told, capecitabine to the Pembro arm. There has been data to show that it is acceptable. We can also think of olaparib. They are non-overlapping toxicities. So I think it is high time we start discussing. We may not accept because of the cost, but otherwise the data is there, and there are multiple trials showing towards one trend that it does benefit. We can argue against or for carboplatin addition. We can argue, should we give adjuvant IO or not? That can be arguable. We have data that maintenance may not help, but at least 4 cycles pre-neoadjuvant is something I would offer, and then take it from there. That's what my thought is.
Perfect. Good.
Vikas, may I ask you a question? Quick question.
Definitely, sir.
Do you see any role of PARP inhibitor in neoadjuvant setting in near future to achieve the PathCR? Because PathCR is being a good surrogate here, and knowing the fact if the germline is there, or somatic BRCA for that matter.
So definitely a BRCA positive, I would be looking forward for the results of the trials. But yes, adjuvant it has shown, so there is no way that it won't show in the neoadjuvant. But then again, data is data and trials are trials. We would be looking forward for
I
it.
think so. There is only data from Talazo
Neo-Tela study.
Yes.
and that data is impressive. That data does show some good PathCRs, but I would not be offering them at this point based on the present evidence. The data is definitely weaker than a immunotherapy neoadjuvant.
Easy, sir. Sir, 50% either had a progression or a stable disease. So
Yeah.
Neo-Tela probably may not be the right way till now. So far at this moment, I think so that what sir also said is, I will not use it because that data has not been as impressive as the data for chemo or IO is. Sir.
Okay.
High rate of progression and a stable, more than 50%, around 48 to 49% was the thing we got from it, some degree of response. That was far lesser that was expected.
And PARP inhibitors is not a simple drug. We all know that
Yeah.
from our situation. So I would be reserving my drug for the same.
Great, thank you, Vikas.
Yes, sir. Thank you so much, Vikas. Sir. Thank you for the nice discussion. But as the time is also moving on, so we all move on for the talk by Dr. Bharat Vaswani, who is Senior Consultant Medical Oncologist and Hematologist, Yashoda Hospital, Hyderabad. And he's going to talk on neoadjuvant CT for HR positive, HER2 negative breast cancer. Over to you, sir.
Good evening, everyone. Are my slides visible?
Yes, sir. Yes, sir. Very.
Let me thank the organizer for a kind invitation. The topic that is given to me is probably the hardest among the three. Nobody can argue about a neoadjuvant chemotherapy or a therapy in triple negative or a HER2/neu or amplified breast cancer, provided they are more than 2 centimeters. For me, the topic was a hormone receptor positive HER2/neu negative breast cancer. Is there really a role of neoadjuvant therapy, be it a chemotherapy or a hormonal therapy? So some good facts that actually I have been using chemo, I have never used a hormonal, but the concepts are changing. And as I'll be telling you in the guidelines, that has already taken place, that they have started endorsing even endocrine therapy in a neoadjuvant. So some new things I think so that we'll be discussing in the next 10 minutes. The million-dollar question again, why? When to give a neoadjuvant therapy in hormone receptor positive breast cancer? and whom to give this neoadjuvant therapy in a hormone receptor positive breast cancer. Now, when you look into the simple ESMO guidelines about early breast cancer, this is what has been given where you can think of giving a neoadjuvant therapy. The data is clear. TNBC, the second part, more than 2 centimeter or with positive axilla regardless of feasibility of optimal surgery. But for then, is only 2 centimeter enough to choose neoadjuvant therapy in luminal breast cancer? I think so. The answer is no. This is not enough to decide whether we should give a neoadjuvant chemo because there is no advantage when you compare it with the adjuvant therapy. So the answer is this cannot be decided as a guidelines to put your patients on a neoadjuvant therapy. So what should be the criteria? So that is basically irrespective of whatever is the genomic data. If you need to give a neoadjuvant therapy, whatever be your ER, PR, HER2/neu, you have to give it. And these indications are simple, as everyone knows. This is an old-time learning. A T3 N2 disease, inflammatory breast cancer disease, and if you have a large tumor and you are thinking of doing a breast conservation therapy, you need to give your neoadjuvant therapy. And that is what the standard guideline, what we have, irrespective of whatever be your ER, PR, and HER2/neu. Now, what we all know is neoadjuvant versus adjuvant chemo, no significant difference for distant recurrence or a breast cancer mortality. So you may give it in this group, neoadjuvant or adjuvant, but that basically it is all depending upon the nature of the disease. What we also know is the complete clinical response, or what we call as pathological CR rate in a luminal type of cancer is far lesser in what we have in a triple negative and or a HER2/neu amplified disease. So probably pathological CR here is not a good surrogate marker for deciding an overall outcome of the trial. Again, pathological CR, no pathological CR, there is effect on event-free survival probably is not as much. And more importantly, no strong association between a pathological CR and long-term outcome in these subset of patients. So as I'll be discussing what should be the surrogate markers, that will be discussed in the later part of my presentation. What if I not use a pathological CR? So whatever trials have suggested that even if you don't take a pathological CR, a residual cancer burden. So a 0 means a complete response, or a 1. Probably these two subsets, if you see, have more or less a very good outcome in a long run. So you may not have a pathological CR, but maybe less than a pathological CR, but a very high response rate may have some better survival when you give a neoadjuvant chemo in a neoadjuvant in these luminal breast cancer side. Now, the main thing that I wanted to discuss is that the guidelines remain same. 4 cycles of AC followed by 4 dose dense 2 weekly Beckley, or a weekly Beckley, or a 3 weekly dosing. This remains the same for all sorts of breast cancer. What is more important is there a role of neoadjuvant endocrine therapy, and are we not denying, or is it something inferior or equal to if we give a patient neoadjuvant chemo? So what it has been suggested that it is definitely a viable alternative for patient who has a low KI. Is this low KI defined? So in most of the study, less than 10% what has been defined. So if I have a strong ER/PR positive, low KI, if I have a genomic scoring less than 12, no doubt at all. Even less than 18, as I will be discussing, it has a very good chance of having a partial or a complete response. This may not be relevant, but in a COVID era, I think so this would have been if it has already been probably lesser, but then you may not be harming your patient. If you plan for a neoadjuvant endocrine therapy in a patient, we would think of giving this approach. And more importantly, being a good prognostic disease, the best way again is if you can test your new drugs in this setting, probably a faster thing to tell. Although I think I'll be disappointing to tell that the data in the neoadjuvant in most of the trials is negative only. Chemo versus endocrine therapy, what should come? This is something of a surprise to me. What I have gone, or there were 3 landmark studies. There was a GCAM study, there was a NeoScent study, and there was a big study. Now, when you look into the study and when you look into the curve, it is variable, but the take-home message at the end of meta-analysis was a similar clinical response, a similar radiological response, a higher amount of BCS. If you see the right side, in a neoadjuvant endocrine therapy, the BCS was better in fact, but with a lower toxicity. So on a Monday morning, if I have a patient who has a Ki61 less than 10, you think of it, Definitely, this approach is acceptable because none of the studies or even the meta-analysis says that giving a neoadjuvant chemo is better than a neoadjuvant endocrine therapy. The similar thing in this landmark time, if you see, overall response rate, breast cancer, in fact, is better with endocrine therapy in all of the studies which were randomized. Please remember, this approach is for post-menopausal, not for a pre-menopausal. So this is what is given in the guidelines. And when you should never expect a complete response because it is less than 5%. The problem is that how long to give an endocrine neoadjuvant is not defined. We give it for probably 3 months, that is in most of the study. But what has been suggested that higher duration is associated with more number of patients achieving a pathological complete response. But probably for an old lady who may probably not be willing for a surgery, this could be one of the approach because over a duration of time, the PAT-CR is improved when you give a long-term hormonal therapy. This is one slide I wanted to discuss that if the recurrence score is less than 18, see, 55% of the patient has either a complete or a partial response, as against recurrence score of more than 31, where hardly 22% have this. So if you are lucky enough to have your recurrence score, and if it is low, less than 12, no thoughts at all, as has been given in San Antonio guidelines also, that you can think of giving an endocrine therapy because it is where probably it may work better than even chemotherapy also. So if pathological CR is not a predictor of response, what should be the predictor of response? So this is probably in last 3 years for all these trials, you are hearing the score, PEPI score, preoperative endocrine prognostic index, based on 4 concepts. What after giving your endocrine therapy, what is your T stage at surgery? So T1, T2, good, better, node negative, better. If your Ki67 is less than 2.7%, better. And if your ER still remains strong positive after treatment between 3 to 8, it is better. So if you can satisfy all your score, your PEPI score becomes 0, it becomes low risk, and you, without any thought, you can put him on an endocrine therapy. Has it been validated? So part of 2 trials, P024 study and IMPACT, it has been suggested that if your PEPI score is low, probably this is one of the better markers to project overall survival in those who are being given this endocrine therapy. And this is something I think is a lot of variability. So you can always keep on discussing. But the biggest trial till date for neoadjuvant therapy in luminal, if it is MCQ, it is a poetic study, 4,486 patients. Preoperative therapy 2 weeks before and following surgery. Please remember the primary endpoint, time to recurrence, was equal. So this surgery was a negative. So giving a neoadjuvant did not help. But for a patient whose Ki67 was less than 10% at 2 weeks, probably these were the patients. So if your Ki67 at 2 weeks is less than 10, probably these are the patients who will do the best in a long run. So some idea to suggest which are good prognostic. $1 million question. We are just discussing CDK4/6 in metastatic where it is a standard of care. Even in adjuvant with monarchy, you have a place for abemaciclib. What about adding this CDK4/6 inhibitor in neoadjuvant? This is something that we need to remember. Please remember, don't discuss your neo-monarch because these were smaller. 2 biggest studies till now is a phase 3 randomized study comparing ribo-letro versus letro alone in patient with HER2 negative 2-3 more than 2 centimeters. The primary endpoint was PEPI score at surgery. What this surgery suggested that at 2 weeks, more number of patients had Ki67 less than 10. So means it is more potent. But the $1 million question is, did the PEPI score become low or 0 for more patients when you added CDK4? So the answer is a big no. Even when you add this, it doesn't add anything to your PEPI score. So probably a negative study, no need to remember. What about molecular downstaging? This is the last part. So a Coraline study, which again, in one arm, there was AC followed by Taxol, and in other arm was Letra with Ribo. They compared PAM score at baseline and PAM score at day 15. And what they suggested is no advantage. The risk of recurrence score was 46% at 2 weeks with chemo as well as with a letrozole. So you can call it, if I don't want to use my chemo, I can use it because my PAM score comes down equally as compared to chemotherapy, which was probably the standard of care. But yes, it is not better than chemo when you think of molecular downstaging. So for CDK4/6 inhibitor, it can definitely reduce your Ki67 more potently or better than letrozole, but there is no improvement in overall response rate and pathological response versus endocrine or chemo with only low rate of pathological CR. So its use at present in neoadjuvant remains investigation. I may not suggest you today, but yes, this is something for you to discuss. The last slide. The most important for me is now in triple negative, I can decide what about a hormone positive. Can I decide based on giving some sort of a endocrine therapy at the end of 4 weeks to see whether I can deny or I should not give chemo to all my patients. So a good study for a patient with recurrence score of more than 25 or N2 and 3, straight away go to chemo. For a recurrence score of less than 12, straight away go to endocrine in adjuvant. What about 12 to 25? So 3 weeks of aromatase inhibitor or tamoxifen, see the score again. If the Ki-67 is less than 10, give only endocrine therapy and avoid chemo. The important thing was at 5 years, the invasive DFS was equal. So probably in future, you will see a lot of these studies based on your recurrence score or Ki-67 less than 10 to may decide which patient may avoid chemotherapy in the adjuvant setting. So most important thing. So the last part, what does guidelines say? So I asked you 2 questions, why, when? So the guidelines say that it should be, it has already hormone receptor positive, HER2 negative in whom chemotherapy decision can be made without surgical pathology and or tumor specific genomic testing. So if you have a patient who needs a neoadjuvant, even whatever be the ERPR, you should give it. That is what, when and why. So without any surgical pathological data or tumor specific genomic testing. But to whom you should give it? To post-menopausal patient with hormone receptor positive, HER2 negative patient, neoadjuvant endocrine therapy with the aromatase inhibitor may be offered to increase loco-regional treatment option. If there is no intent for surgery, endocrine therapy may be used for disease control. For pre-menopausal, yes, neoadjuvant endocrine should not be routinely used outside the clinical study. What did St. Gallen's give? So 5 lines have been given for neoadjuvant in ER positive. So for post-menopausal women with low grade or low risk genomic signature, 98% of the patient agreed that chemotherapy may not be used. So did not agree that chemotherapy was a treatment of choice. I did not know this, 98%. And 73% of the panelists voted in favor of performing a genomic assay on core biopsy to select patient for ER positive breast cancer for neoadjuvant. So a low score probably is the way to go whenever we have this data. And I think it will be safer now to use with the increased availability of the good data. So if I have to summarize, use of genomic assays and Ki-67 may best select patient who may benefit from pre-operative chemo or endocrine therapy. Neoadjuvant endocrine therapy is a safe and effective alternative to neoadjuvant chemo in this hormone receptor positive breast cancer patient. But I think so there is a lot of research going on, and I think so the data is not out. You can still use it, and there is a lot of, you can still have a debate, but trials now are in progress will broaden this neoadjuvant endocrine therapy indication and or a chemotherapy indication in high risk HR positive. So probably for those with the Ki-67 or more than 10, whether you can use this or not, probably future trials will tell us. I thank you all for a patient here.
Thank you so much. Thank you so much, sir, for the wonderful talk. And 1 minute for asking the questions. Just 1 minute. Any question?
Dr. Bharat, wonderful presentation, and I think only you could have done justice to this topic. Wonderfully presented. I remember one of my patients who I gave neoadjuvant endocrine therapy, especially because of the cardiac status of that patient. The ejection fraction was 27%. Luckily, in that patient, the Ki-67 was 10%. And the patient was able to undergo surgery thereafter. So just an addition. Wonderful presentation.
What we have now is Ki-67, probably less than 10%, grade 1. Grade 3, I may have my doubt because but if Ki-67 is less than 10, this is grade 1 or maybe grade 2. If the patient is not, I may think of giving this because, sir, we have whatever randomized studies were there did not show any of the studies that there is definitely some improvement. Probably our concept still is we give chemo, but the data is what is suggesting that you may not be wrong, but then you have to choose your patient. And again, it depends all our pathologists' help. They may tell us the right patient, probably that is still, because genomic score for us is a difficult thing because of the cost constraint. But I definitely think that this is a way to go And the recent trials all are trying to look into. Maybe next 2, 3, 4 years, neoadjuvant, you may get earlier data. It may help us more.
Yeah, Dr. Bharat, wonderful presentation. I hope the time permits one more question and discussion.
Please, sir, please.
Ji, sir.
So I think wonderful. I think you've really raised a very important question. So what I felt is then, like I think Rahul also was saying, in some of the patients who are not fit for chemotherapy in the postmenopausal setting, we use the hormonal therapy as the neoadjuvant manner. And these patients don't respond so soon, but they take time, 3 months, 4 months, 6 months, and then they respond almost, they have a CR to the extent of when we propose the surgery, they refuse it. And without surgery, they carry on and they actually do very well. And sometimes we think that, okay, should we just give radiation or leave them? And so such a wonderful response we see.
Sir, concept is changing. I agree. Now with the
Yeah,
data,
okay.
I think so that is, now we have started realizing with the data,
Right,
probably more and more
So,
usage may give us more
The
confidence.
other thing which ever since we have been using the CDK4/6 in the metastatic setting, especially in the oligometastatic settings, we've also seen that the patients go into CR and at the end of 3 years, there's no disease left neither in the breast nor anywhere else. And then we are failing to understand as to how to proceed. Now, I think that is another experience which can add to the neoadjuvant concept, that maybe we will have an opportunity to use the CDK4/6 in these patients for a longer time. 3 months is too short time to, for these drugs to be showing their efficacy. I think maybe 3 months, 6 months, I think that should be the way forward. I think that's
Wonderful. Excellent points. Excellent
Thank you.
points.
I have a point to make. For CDK4/6 inhibitor, the probable subset where it will work will be the patients who have high Ki67. If you use a low proliferative disease, I don't expect any response with the CDK4/6 inhibitor anyways. It has to be higher actually.
So probably a
Agreed, Dr.
grade 3 ERPR positive. Maybe sir, that should be.
Agreed. So I think we have both subsets, low Ki67, high Ki67. I think that's the way to go for.
Yes,
Absolutely.
I think that's a good point, Amit.
So we proceed further. So it's
Thank
going
you.
wonderful. And we proceed further for the talk on neoadjuvant CT for HR, HER2, new positive breast cancer. And for this, I would like to invite Dr. T.P. Sahu, who is Consultant Medical Oncology, Silverline Hospital, Bhopal. Over to you, sir.
Yeah, I'm audible and my slides
Yes,
are
sir.
visible.
Yes, sir, very much.
Okay. So in the next 5 to 10 minutes, I will go ahead and to look at the neoadjuvant approach to HER2 positive early breast cancer. Nothing much has been added in the recent except for the ADAPT, which was published this year, which will speak a little bit on that. But let's go into what has been the story all along. This actually started off with a 2005 article from MD Anderson. There were some 40 odd patients, and they were taken up for chemotherapy versus chemo plus trastuzumab. It was a very small subset, and actually, if you look at it, it was chemotherapy was a taxane and FEC, and otherwise it was a trastuzumab with chemo plus taxane, and the trastuzumab given all along with the chemotherapy, and they found the patients to having a more significant pathological CRs, and this is where the concept comes from. And the pathological CR was actually nearly 3 times that of what was achieved in the chemotherapy alone arm. And this trial and multiple trials and all put together in the meta-analysis does give us this thing that the meta-analysis shows that the event-free survival and the OS is beneficial if someone is achieving a PathCR. And to achieve the PathCR is the question why the neoadjuvant approach has been talked about, not only in the TNBC, and we saw that in the HER2 hormone positive disease, where the data is probably the weakest, as Bharat told, but this data has been quite strong in the HER2 positive scenario. And to look at and find those PathCR, we as oncologists have been adding drugs in the neoadjuvant. That's one point of it. The second point, what I think why people like us are thinking of adding drugs in or putting the drugs into neoadjuvant setting is to do a tailor-made therapy as per the response in the adjuvant setting. So this is 2 things why probably neoadjuvant therapies are slowly picking up. And there was a lull. There was a good interest 1 decade back, then there was a loss of interest, and now the interest is being regenerated for neoadjuvant treatments. Then came the NOAA trial. It was a phase 3 open label trial for neoadjuvant trastuzumab. This was a trial which looked at the HER2 positive and HER2 negative patients. There were some 100 odd HER2 negative. Let's leave that apart. Look at the 200 odd patients who had trastuzumab with chemotherapy versus chemotherapy alone. Again, a very old trial published in 2010. And all the patients went ahead and received adjuvant trastuzumab and to complete the 1 year of treatment. The trial showed two things, that if you added trastuzumab to the chemotherapy skeleton, or you added the trastuzumab to the in the adjuvant setting with the neoadjuvant instead of chemotherapy. Basically, the addition of trastuzumab both in the neoadjuvant and adjuvant to a neoadjuvant chemotherapy did show a benefit in the EFS and OS, which was significant. So this trial did show that yes, there was a probable role of again adding a neoadjuvant trastuzumab, although there was ambiguity that all this patient did receive adjuvant trastuzumab, but both the arms put together did benefit. That addition of trastuzumab to neoadjuvant approach of chemotherapy was beneficial in oncological outcomes. So if we look at the neoadjuvant setting and leave the ADAPT out, if you look at we have the Neosphere, the Trifina, the ADAPT which is there in the pertuzumab on the right hand side is something that has been the last data which is put up. If you look at the neoadjuvant setting for the lapatinib, the NeoAlto has been the most spoken about. We have something on the CalGB data and the NSA B41, but the most spoken about for the neoadjuvant lapatinib is the NeoAlto. And if I look into a very straightforward question, who should receive a neoadjuvant HER2 target therapy? Let it be a dual, probably is better than single, is anyone who has more than 2 centimeters. But where does the data evolve from? The first big trial that was put up for the neoadjuvant setting came from the Neosphere. Mind you, it was a phase 2 trial. It was a 4-arm trial, which had 417 patients, and they took up any patient who was operable or locally advanced or had inflammatory breast cancer who was beyond 2 centimeters of primary tumor. Therefore, the arm A was the TH, that was the trastuzumab and the docetaxel. Then we had a docetaxel, pertuzumab, and the trastuzumab. Then we had arm C, which was a non-chemotherapy neoadjuvant, and the arm D, which was docetaxel and pertuzumab. So mind you, here we had uniqueness that arm C did not have chemotherapy, and all the chemotherapy was received in the adjuvant setting, and all the rest arms, that is arm 1, arm 2, and arm 4, that is they call A, B, and D arms, they received the same amount of chemotherapy both on the adjuvant, neoadjuvant, and the adjuvant setting. The second trial that will be spoken of together is the Trifina, again a phase 2, but this trial, although they looked at the addition of anthracycline versus no addition of anthracycline, but the primary endpoint of the Trifina was did the anthracycline addition to a target therapy, let it be dual here, add to these cardiac safety concerns. So we have two data which I'll speak together, and then I'll go to the other data. If you look at the Neosphere, much spoken about data, we did speak about it a lot in the last 7-8 years back. This did show that the PATCR was highest for the patients who received a dual HER2 target therapy along with the docetaxel in the neoadjuvant setting. That was point number 1, but this has to be taken with a pinch of salt. No oncological outcomes, let it be the DFS and OS was superior. There was some amount of superiority for the pertuzumab arm with trastuzumab, but it was nothing significant. If you look at it, the lower part of it, all the confidence interval were wide. So basically, none of the arms had the power to show superiority in oncological outcome. It was a trial mainly designed to look at the PATCR, and that was somehow positive. If you again look at this upper curve, it showed that the patients who had a PATCR did achieve and had a better oncological outcome than those who did not have. All of us know that, and this has been shown trial after trial. But problem is that, like in Neosphere, only 77% of the patient did not achieve a PATCR. Only 23% patients achieved a PATCR. So basically, we look at it not majorly in the whole trial put together, not the dual HER2 targeted, where there is much higher numbers. But so even if you look at the 77% who did not achieve a PATCR, there is data in the Neosphere that patient who received a dual HER2 targeted, in spite of not achieving a PATCR, actually addition of pertuzumab did benefit on the oncological outcomes, especially the event-free survival. So what I mean to say is there something in addition of pertuzumab that has a carryover effect that adds to the benefit in spite of patient not achieving a PathCR is something we need to see. And this has again been proven and shown in a NSCB B18 that patients who did not achieve PathCR and did take pertuzumab continued to do benefit more than patients who did not achieve PathCR, but there was no addition of pertuzumab. So basically, I want to say that probably if you are adding a new adjuvant, pertuzumab to a trastuzumab to a chemotherapy skeleton, patients who achieve a PathCR are definitely going to do better because they achieved a PathCR per se, but those who do not achieve and partial response is achieved probably will do better with addition of the dual HER2 targeted therapy than a single target therapy. So this is what I wanted to speak about this NEOSPHERE trial. The TRIFINA shows one simple thing, that the triple negative patients, sorry, the ERPR negative patients did better than the ERPR positive. But if you look at the other outcome, did the addition of anthracycline benefit in any way? Although it was not the primary endpoint, if you look at these survival curves, it was actually superimposing each other. So this again points to that is anthracycline a very essential component of a chemotherapy skeleton for a neoadjuvant therapy in regards to HER2 targeted. And if you look at when I come to TRAIN trial, again this whole thing will be re-spoken once again. Now coming to the lapatinib, again old trial. If you look at it, published in 2010, around the same trial when the NOAA was published, the NEOALTO was the trial. All of us know that it was initially going for a HER2 targeted treatment for 6 weeks, then add paclitaxel to the skeleton. So basically, you have starting the HER2 targeted, let it be single, let it be dual, and after 6 weeks you add paclitaxel. So there were 3 arms: lapatinib alone versus trastuzumab alone versus the combination of lapatinib and trastuzumab. Look at the response data. It showed that the dual HER2 targeted at 6 weeks also was statistically superior responses than the single agent HER2 targeted, and lapatinib did better than trastuzumab. But once the chemotherapy was added, the benefit actually shrunk. But although still the combination of the dual targeted therapy of lapatinib trastuzumab with pacli did better and on regards to response to the single agent HER2 targeted with paclitaxel. Again, if you look at the conclusion, the updated of the NEOALTO confirmed patient who achieved a PathCR had a better EFS and OS. The difference was mainly observed again in the hormone receptor negative, as we saw in the TRIFINA trial. The EFS OS after 6 years did not differ significantly. Again, all the same thing comes in. These trials were underpowered to detect a modest benefit that could have achieved. If you look at affinity, the benefit of an adjuvant dual therapy was a 3 to 4%. It was a very small benefit that really happens if that. So these trials were not powered to look at this benefit. And the second point that went against the lapatinib was the ALTO trial. So the ALTO trial in the adjuvant setting became a negative trial. But if you look at the description and even the literature, it points out that the FDA meta-analysis method, I cannot go into description of that, there was no discordance between the ALTO and the NEOALTO. What they proved that there was a response, there was a benefit, and there was a inclination to go for an event-free survival benefit for the PathCR patients who achieve PathCR in both, and the ALTO and the NEOALTO actually told the same thing. I cannot explain it in a short time what they meant, but basically it all tells you that HER2 targeted therapy in the neoadjuvant setting does have a role. If you have to do it in the neoadjuvant setting, the dual approach would be the way. The major responses has been, or the major evidence has been with the pertuzumab and the trastuzumab rather than the lapatinib, although the NEOALTO was still a positive trial. Now look at what I do if I do not achieve a PathCR, and especially for patients whom you have given HER2 targeted therapy in a neoadjuvant setting, and if they do not achieve, all of us have seen this Catherine data set multiple times, so I don't want to go into much of it, just to tell you that the trastuzumab alone in this Catherine trial was approximately 80%, only 20% had received dual target therapy. So basically, can we put this conclusions of the Catherine into the patients who received pertuzumab trastuzumab as a dual therapy? I could not say, because most of these patients in this trial had received only single agent trastuzumab as neoadjuvant. Probably this trial is more pertinent in the Indian setting because many of our patients do not take dual agent target therapy in a neoadjuvant and only take trastuzumab, and probably in those patients, if you look at it, there is a benefit of the invasive disease survival if you add TDM1 versus continue trastuzumab. And this was there irrespective of the subsettings of ER positive or not positive. My second point was there was a difference in the benefit. Again, distance recurrence was
Request you to
beneficial.
conclude your presentation in 1 minute.
Yeah, sure. And the OS, there was not much of a difference. So if the train, I go to the last slide, which I want to show you. Again, it was a neoadjuvant study. Just to tell you the simple thing that there was no difference in the response in the PAT-CR rates if you add anthracycline or you don't add anthracycline. So what I mean to say is, if you look at how I look into that, if you have anything more than 2 centimeters and you intend and you believe in the approach of neoadjuvant, then probably the trastuzumab and the pertuzumab skeleton will be the way to go forward. The lapatinib arm in the NeoAlto could be approached, but mind you, there is no trial which shows the OS benefit or any oncological long-term benefit with the neoadjuvant approach. But definitely all of the trials point towards event-free survival if the patient achieves a pathological CR. And not only pathological CR, even the partial responders also do achieve an event-free survival. I end my my talk with this one slide. This trial does show you that the event-free survival is majorly there with the combination of the HER2/neu targeted therapy, especially the dual agents plus chemotherapy, than only chemotherapy in the neoadjuvant. So if someone has to do neoadjuvant, that is the way which I've already told. With that, I end my talk here and thank the organizers for giving me this opportunity, and I will be open to any small question if there is any. I would just want to finish off with ADAPT, which was published in Lancet. There was a 5:2 randomization. This told two things, that if you have a short course paclitaxel plus a dual HER2/neu targeted, that could be the way. And if the patient achieves the PAT-CR, you just may take away the adjuvant chemotherapy and just continue with the targeted adjuvant HER2/neu treatments. So this is the last which I wanted to speak on this data set of neoadjuvant HER2/neu target therapy.
Thank you so much, sir. Thank you for the wonderful talk. And next we move on to the session sponsored by our academic partner, Eli Lilly. And for this, I would like to invite Dr. Vikas Talreja, who is Senior Consultant Medical Oncologist, Regency Hospital, Kanpur. And he's going to talk on clinical significance of PIK3CA and ESRI mutations in ctDNA and FFPE samples from the Monarch 2. Over to you, sir, for your talk.
Thank you. I hope I'm audible and visible right now. And I would request the organizers to share the slide set again from my behalf.
So do we have Ankit? Do we have sir slides?
Yes, you will be having it. That's for sure. I thank Lilly wholeheartedly for supporting on the slide sets on their behalf. And I thank the organizers, Dr. Rahul Su personally, for considering me for this talk. I thank the chairperson for this talk, Dr. Ranga Rao, personally, because he has been an alma mater and a guiding limelight for all of us. A very important topic we will be discussing is the abemaciclib plus fulvestrant, a very clinically significant PIK3CA and the ESR1 mutations in the circulating tumor DNA and the fresh frozen plasma samples for the Monarch 2 study of abemaciclib. 2 slides forward. So the background of this is basically the Monarch, next slide please, was a global double-blind study, phase 3 study in hormone-positive, HER2-negative advanced breast cancers whose disease has progressed while receiving prior endocrine therapies. And abemaciclib plus fulvestrant significantly improved the PFS and the overall response rate versus the placebo plus fulvestrant. Now, the exploratory analysis included all clinically subgroups had a benefit from the addition of abemaciclib to fulvestrant, and based on this Monarch 2 data, the CDK4/6 inhibitor abemaciclib became a standard of care. Now, aside from the ER positivity, predictive markers for the biomarkers for the clinical benefit from CDK4/6 inhibitors are remaining largely unknown. And we know that PIK3CA and ESR1 are implicated as a resistance mechanisms to the endocrine therapy in hormone-positive metastatic breast cancers. ESR mutations, even though they are rare in primary breast cancers at the time of diagnosis, but during the course of the treatment, they tend to develop more ESR1 mutations, and they have been found in much more higher incidence with the retrospective data analysis that we have. PIK3CA being PIK3CA can be in primary and metastatic breast cancers. And all of these, if we look across in various trials, next slide, the BELLE-2, the Sandpiper, the SOLAR-1, the PALOMA-3, the Mona Lisa, all the CDK4/6 inhibitors, the PFS is slightly shorter with the PIK3CA mutations identified in the circulating tumor DNA. So if you look at the Buprelizumab circulating tumor DNA, the median PFS was 7 months as compared with the rest of the standard of care with the PIK3CA mutations, those are there. Similarly in Alpelisib also, and similarly in Paloma trial and the Mona Lisa trials, even though these are cross trial comparisons, but yes, we see that PIK3CA mutations does affect the progression-free survival, whether they are present in the circulating tumor DNA or they are detected via FFP samples. So this trial was basically to assess the frequency of the PIK3CA and ESR1 mutations in tumors from the patients treated in MONARCH 2, to assess the concordance of PIK3CA and next slide, please, the ESR1 mutations from the circulating tumor DNA and FFP tumor samples in the MONARCH 2. And next slide, please. To assess the correlation of the circulating tumor DNA in the PIK3CA and the ESR1 mutation status with the treatment benefit who are treated particularly with the abemaciclib fulvestrant combination as compared to those with placebo plus fulvestrant. So if you look at the study design of it, a very fairly simple study design, you look at next slide, please. The MONARCH 2 population, we know they were randomized as whatever the abemaciclib plus fulvestrant and placebo plus fulvestrant. And basically, the archive baseline tumor collection samples comprised of more than 70% of the primary breast tissues, and the average age of the tissues was around 38 months, that is 37.5 to be exactly. And the circulating tumor DNAs were locally processed within 16 minutes of the blood draw. And the method that was used for detection of these mutations was the PCR method, droplet digital PCR to be exact. So they were tested for the 4 mutations in the E3C and ESR1 pathway, and individual digital droplet PCR assays for each variant of the interest was performed on a PCR system that was Bio-Rad QX200, which is a fairly standard system, and the samples that failed quality DNA or were intermittent mutations were excluded from the analysis. Classified positive only if there was at least one of these mutations present within the. If we look at the patient demographics and the disease status, the PIK3 mutant and PIK3 wild type and the ECR mutant and SR wild type. If we look at the baseline demographics were exactly matched in the either of these group based on their race, whether they were Asian, Caucasian, or other, whether they were endocrine naive, endocrine therapy naive, or endocrine therapy. 2 slides, please, forward. Next and next. Or they were whether prior and aromatase inhibitors was used or not. So they were exactly matched by the plasma mutation status of the whether they were PIK3CA mutant or they were ESR1 mutant types. And if you look at the disease burden also, whether there was a metastatic disease or it was only bone only disease, visceral disease. So this was the abemaciclib plus the fulvestrant MONARCH 2 trial, and the demographics were fairly standard for each of them. Now, if we look at the major analysis, the endpoint, the frequency of the PIK3CA mutation, next slide, please. So PIK3CA mutation was detected in 40% of the patients with evaluable plasma samples and 40% of the patients with evaluable FFP samples again. So the concordance rate of the PIK3CA mutations between the plasma and the FFP were 62.8%, which is quite high. Now variants which were the most common was detected was the 1047R, which is barely the standard which we all detect, the 545K, the 542K, and 1407L, is something which is less in literature also, and that was fairly standard in the same. And if you look at the ESR mutations, please 2 slides ahead. Again, ESR mutations were fairly 65% in the patients with available plasma samples. However, 4.4% were detected in the FFPE samples. And we could look at, there was a lower incidence of the ESR mutations between plasma and FFP concordance being around 37%, showing that there wasn't a great discordance between how we detect in blood and how we detect in the tissue. And with intent to treat population analysis between the plasma biomarker solution, the addition of the abemaciclib plus the fulvestrant. Next slide, please. If you look at, again, those who were detected, it had a significant benefit, as you could see, with the hazard ratio of 0.58, meaning a 42% reduced chances of progression when you add abemaciclib to the fulvestrant group as giving only placebo, with a median PFS of 11.4 months in the plasma biomarker population, and in intent to treat population where it was 93 months. Now, if we look at the circulating DNA PIK3CA mutation status, again, abemaciclib did have a very incremental benefit with the median PFS of around 15 months, while in the placebo group reaching up to 5.7 months with a hazard ratio of 0.46, meaning there was, next slide please, a 54% reduced chances of progression when you detect PIK3CA mutation for and add abemaciclib to it. So therefore, the performance of fulvestrant in mutant and wild type group is consistent with the historical data, demonstrating that PIK3CA mutation is a worst type of the mutation that to be demonstrated. And PIK3CA mutant tumors derive numerically greater benefit from the addition of the abemaciclib to fulvestrant than those with the wild type of the same. Now, if we look at the ESR1 mutations also, next slide, please. Again, ESR, when you add abemaciclib to the fulvestrant, the median PFS was 21.9 months as compared to 10.3 months with the placebo and fulvestrant. That if you look at the contemporary group of the wild type of the ESR, it was 11.6 versus 16.3. And if you look at the hazard ratio, again 0.49, meaning a 51% reduced chances of progression when you add abemaciclib to the fulvestrant group in those which ESR wild type. And that's where the wild type mutant, the ESR mutant tumors derive numerically greater benefit from the addition of the abemaciclib to the fulvestrant group. Now, again, if we look at how we detect the circulating tumor DNA, why we detect it by circulating tumor DNA, we could see that in next slide, the 36% of the patients had tumors with mutations in both PIK3CA and the ESR1 mutations. And when both of these are present, you look at the hazard ratio of 0.48, meaning a 52% reduced chances of progression. And that was the group which derived the maximum PFS benefit out of it, which is 17 months as compared to the worst.
So would request you to conclude your presentation in 1 minute.
Perfect, perfect. So the limitation of this explorative analysis, next slide, was that yes, there was a small sample size because these were treated in Monarch 2 studies. They were archival tissues with an average age of around 3 years. Next slide. It was a disproportionate number of the breast primary samples, and it is definitely a hypothesis generating and needs validation in suitably powered prospective trials. So to conclude, the last slide. In this exploratory analysis of Monarch 2, the addition of abemaciclib to the fulvestrant demonstrated an improvement in the progression-free survival regardless of the PIK3CA mutations or the ESR1 mutations status in the circulating tumor DNA. There was a numerically greater magnitude of benefit for patients with tumor harboring PIK3CA mutations or ESR1 mutations with an hazard ratio of 0.46, meaning a 52% reduced chances of progression with the PIK3CA mutations versus the wild type, and also with the ESR mutations where the hazard ratio was 0.49, meaning a 51% reduced chances of progression as compared to the placebo plus fulvestrant type. So previously exploratory analysis demonstrated the benefit of abemaciclib in these worst prognostic subgroups, and therefore these data needs to be further concluded in the prospective clinical trials. Thank you for your time, and over to the organizers. And that's it.
Thank you so much. Thank you so much, sir, for the wonderful presentation. And our next session is also sponsored by Eli Lilly, which is a clinical case presentation why I choose emiserlib for my HR positive, HER2 negative MBC patients with poor prognostic factors. And for this, to moderate the panel, I would like to invite Dr. Ranga Rao, who is medical oncologist, chairman, Paras Hospital, Gurugram. And the panelists on board are Dr. M.V. Chandrakant, who is consultant medical oncologist, Narayana Super Specialty Hospital, Kolkata, and Dr. Vikas Talreja. Over to you for your panel discussion.
Thank you very much, organizers, and thank you very much, the Eli Lilly, for giving me this chance. So how we'll go about is I'll present my case, and followed by Dr. Chandrakant, he'll present his case, and then we'll have a panel discussion to save time. So I'll be quick with my patients. So this is these are my disclosures. And then this is the patient, 80-year-old lady who presented with a lump in the breast and the left breast, and she did not fortunately have any comorbidities. There was no family history of cancers. And then we did the workup completely, and after workup we found that she, on the PET scan, she really had a nodular lesion in the upper right quadrant of the breast, and then also in the multiple lymph nodes in the axillary region, supraclavicular region, and pulmonary nodules. And then there were some bony lesions as well. The biopsy revealed that she has got a ER positive, strongly positive, PR strongly positive. HER2 was initially 2+, and we did the FISH negative. Ki67 was 30%, and so she was a T4 lesion, and then M3, M1, which is the stage 4. And this patient had this is the PET scan that you can all see, the lymph nodes in the supraclavicular area, and then the left breast and the axillary nodes, and some mediastinal nodes as well. And the lung metastases were seen, and a couple of very small bony metastases were also seen in this. So what next? I mean, we got over all the things, and I think this debate is over right now. So the first choice always would be the AI with the CDK4/6 and an 80-year-old patient, and the choice would be between the CDK4/6 inhibitors, and we chose the abemaciclib, and that's simply because the MONARCH 3 trial is one of the trials which has shown that the survival benefit is almost like doubled, from 14.8 months to 28.2 months in the PFS as compared to the placebo, and that is one important reason why we put this thing. And also we chose the thing because we wanted a shrinkage of the tumor much faster. In the exploratory analysis, the mean change in the tumor size demonstrated that after 2 cycles, the tumor size in the abemaciclib arm decreased by 27.7% as compared to the 16.6 in the placebo arm. So not only it is efficacious, but also it gives a rapid shrinkage of the tumor. So in this patient, after testing for all the baseline labs and the complete evaluation at 80 years, whatever she deserved to have, we started on the abemaciclib, letrozole, and the zoledronic acid for this, because we did the bone densitymetry, and then she did have some the negative value of the bone density. So we explained to her the whole prognosis, the standard manner that we do, and then patient was tolerating the treatment well. We were apprehensive about starting the abemaciclib, but fortunately, she did not have any hematological toxicity, any diarrhea, and then she was on a continuous regular follow-up monthly through the video conference during the pandemic, and subsequently she was she's been coming to us very physically also. And then the PET CT scan showed in the June 21, there's a significant resolution of the supraclavicular and the axillary lymph nodes, significant decrease in the size and the previously noted lung nodules. And because the lung nodules, we could not actually do an FNAC, not only for the risk, but also they were remote and small ones. So we chose to observe her, and then we proven that these lung nodules are nothing but metastatic because they almost like disappeared. So this is the PET scan, which shows the total disappearance of the entire lesion in the breast, in the lung, in the nodes all over. Those small residual measurable lesions on the CT scan were there in the lymph node, but they were all, the PET scan was negative. So it just shows that it was showing a very good rapid response, and the patient had an excellent tolerance. And the additional follow-up, that we've been doing this follow-up every 6 months. And then the last scan was done in April, and then there was no, she had the maintained complete metabolic response. And then she continues to have the abemaciclib, and we just reviewed her. Now, after the experience of the COVID time, she chose to have video calls. No, doctor sahab, video call karte hain, kyun baar baar aana hai? So that's what she does, and then she's doing pretty well for this patient. So this is the April 22 scan, which shows complete response to this patient completely. And then so the conclusion is that the only CDK4/6 inhibitor which has got a continuous dosing schedule. So advantage of the continuous dosing schedule is there's complete compliance. They don't have to remember to struggle to say, okay, 3 weeks on and 1 week off. And so that's one of the important things. And the distinct safety profile with a very minority of the patient experiencing grade 3 and above neutropenias as per the MONARCH trials. And then the patient obviously has to be educated and counseled about the diarrhea, which is fortunately not a big problem in our Indian setting. And we would like to share the views of the audience here also. And 9 to 13 patients had grade 3 diarrhea in both the MONARCH 2 and MONARCH 3 trials, and they did not have any grade 4 diarrhea in these trials. So I think that with that I end, and now I would request Dr. Chandrakant to take over his case and talk about that, please.
Thank you, sir.
You'd like to share your slides?
I'll share, no worries. Okay. Yeah. So I would thank organizers for the opportunity, and Rangarao sir already presented so nice cases. So just in continuum to it, even I do present some of my real world experience. So these are the disclaimers from the sponsor. Well, so I have two cases similar to what sir presented. The first one is a 73-year-old lady who is a strongly ERPR positive lady who completed definitive therapy followed by letrozole for 5 years. And then after a 5-year break, from 2015, 2020, she was off treatment. In 2020, she developed extensive disease, lung, bone marrow. I mean, she was sort of a compromised performance status, she had difficulty walking, grossly symptomatic, had a lot of weight loss. So she was a typical endocrine sensitive relapse who had relapsed after completing 5 years of letrozole and 5 years break. 2015-2020, there was a break. And then this patient had multiple visible mets. As you could see, when the bone marrow was involved with baseline anemia. So I think if you look into the risk factors, all these are important risk factors, including visible disease. Liver mets especially is a poor prognostic factor. Having a performance status of 2 is also a poor prognostic factor. So, well, to my mind, multiple questions did come. As the patient was not in visible crisis, chemotherapy was out of question. So we did plan, the patient was eligible for both AI and fulvestrant, but as the patient had an osteoporotic bone, we chose to offer fulvestrant in combination with CDK4/6 inhibitor. And as this patient had extensive visible mets, if you look at the liver mets, the hazard ratios are better, in terms of 0.4 if there are liver mets. So in those patients which are difficult to treat, adding a CDK4/6 inhibitor like abemaciclib in MONARCH 2 and 3 has a greater delta and a better hazard ratio for progression-free survival. Therefore, this patient was offered abemaciclib in combination with fulvestrant. And this patient had prompt relief in her symptoms with just grade 1 diarrhea and fatigue being sort of a dose-limiting toxicity. In 3 months time, the PET-CT showed near complete response, such rapid, quick and brisk responses and a complete response in very short time with having grade 2 fatigue, grade 1 diarrhea as a side effect. And you can see those images, the lower ones are the ones where you can see the vertebrae which are lighted up on the PET CT. The upper ones, those lighted up lesions are cleared. So you can see these liver mets that were there in the lower row are cleared in the upper row. And these are the PET CT that is showing near complete resolution. So we discussed an elderly lady, frail lady, extensive disease showing quick responses, and it has been now 2 years, 4 months. She has remained disease-free on fulvestrant plus abemaciclib, doing extremely well. My second case would be a 63-year-old lady, strongly ER/PR positive with a fungating breast mass with extensive pleural disease, especially pleural effusion, and a large fungating mass that was there. So she was not in visible crisis, endocrine sensitive patient, strongly ER/PR positive, HER2 negative. Again, having visceral disease is a poor prognostic subset, and this patient was postmenopausal and was eligible for AI plus CDK4. And this is the doubling of progression-free survival in MONARCH 3, 14.8 versus 28.2 months with an excellent hazard ratio in combination with AI. And you can see the hazard ratios are good with visceral mets, with bone-only mets. All subsets have got a significant hazard ratios, and very important to point towards the PR negative subgroup, which is really done well with a hazard ratio of 0.41. So this is the response rates. You know, you can see the responses, everything going down, showing brisk and deep responses with AI plus abemaciclib. So this patient was treatment naive, endocrine sensitive, was started on letrozole plus abemaciclib. I mean, absolutely no side effect except grade 2 fatigue, no diarrhea whatsoever. In our set of patients, diarrhea is not that common in contrast to what we've seen in the MONARCH group of trials, and this is how the lesion just resolved so quickly in a matter of 3 months. You can see the lower PET CT images having such a bulky breast lesion, liver lesion, lung lesion, pleural effusion, and the upper lesion just in a matter of 2 months. Very rapid resolution. So we do see resolution with endocrine therapy, but quick and deep responses is what you would see when you combine AI in along with abemaciclib in this particular patient. So we had 2 patients, postmenopausal, elderly, frail, extensive disease, 2.5 years right now, remaining disease free and having a good performance. She has gained nearly 12 kgs of weight, and the second patient having a fungating mass resolving so rapidly. So this is what is an endocrine therapy can do in an eligible patient. So with this, I would thank all of you for your patient listening.
Yeah, thank you very much. Thank you very much, Dr. Chandrakant.
I'll stop sharing, sir.
Yeah, no, I think we can continue with this because the questions
Okay.
are. Thank you.
Okay,
very
sir.
much. So maybe you'll have to help me to change.
Yeah,
this.
I will move it further, sir, when we see. Yes, sir.
Oh, thank you. So we're going to have a quick panel discussion with Dr. Chandrakant and Dr. Vikas. So yes.
Yes, sir.
So I mean, we just want to know from the panelists as well as from the other people that how does the selective inhibition of CDK4 versus CDK6, I mean, that's a precise mechanism of action matter. And then what impact does this have on your choice of the CDK4/6 inhibitors? So maybe Dr. Chandrakant, you could take this.
So, well, sir, CDK4 is the actual target and CDK6 is something not wanted, you know, it happens as a bystander. So if I can have a very selective CDK4 over CDK6, the marrow is the one that I can actually spare. So if you have more CDK6, you will have more cytopenias, and that's where abemaciclib is different from other CDK4/6 inhibitors. So it is very important to have a preferential CDK4 inhibition so that you can have a continuous dosing and be marrow safe and take care of cytopenias.
So in your experience, Dr. Vikas, this the CDK4/6 and 4 and 6 inhibitors, both, when you use both, has the experience been very different as compared to abemaciclib? Dr. Vikas, I hope he's there. Otherwise, Dr. Chandrakant, I mean, why do you waste your time? Maybe you can take on this, please.
So yes, sir, I think you can look into Palbo or Ribo. They have an intermittent dosing of 3 weeks on and 1 week off because they have a marrow cytopenias as the dose limiting toxicity. So whereas if you have a preferential CDK4 inhibition, you can give a continuous dosing and
Right.
marrow being spared. So that's why this whole ratio of CDK4 and CDK6 is there.
All right. Yeah, fine. Okay. Can we have the next slide?
Yes, sir.
Thank you. So the overall survival benefit. So we're talking about the PFS and the overall survival benefit, and how does it impact your choice of the CDK4/6 inhibitors? I mean, what do you look for in a patient with metastatic breast cancer who is ERPR positive?
So, well, sir, I think two important endpoints in a patient with a metastatic disease is overall survival and quality of life. These are very important endpoints, how long the patient lives and how well the patient lives. So we have seen in Monarch 2, the overall survival, and even in Monarch 3, we are seeing, I mean, we don't have officially the results being out, but again, impressive results. So overall survival is a very important endpoint to have. And unless the drug is actually effective, it is difficult to get an overall survival benefit. Having said that, these are the set of diseases where you have multiple subsequent therapies. So a PFS1 is shorter than the PFS2 plus 3 plus 4 plus 5. So when you have multiple subsequent therapies cross over, chemotherapies coming in, PIK3CA inhibitors coming in, or even PARP inhibitors coming in subsequent lines. So it's a real challenge to actually get overall survival benefit. But however, if you have an overall survival benefit, it just says about early positioning of the drug and the potentiality of prolonging life. So it is very important to have a significant overall survival, but we need to look into the study design and what are the subsequent therapies these patients have got.
Yeah. Right, thank you. And then I think you're the only person who's going to disconnect.
So
Can we have-
Vikas Talreja is having some emergency, so he has just messaged.
That's not a problem. We'll manage. Thank you. So the next slide, please.
Yeah.
Right. So what about the endocrine backbone? I mean, we listened to these trials of the abemaciclib with fulvestrant, abemaciclib with letrozole, and we have with the anastrozole and all that. So what is the endocrine backup that which you like to use with abemaciclib?
So fair enough, sir. I think we have both evidences of non-steroidal aromatase inhibitor and fulvestrant. And we also have a trial in combination with Palbo, where either of the endocrine agents can be used. I think both of them can be used interchangeably. The only setting is when you have an ESR1 mutation where you would prefer fulvestrant over an aromatase inhibitor.
Yep.
So I would use interchangeably both of these, and I don't think it compromises survival or outcomes.
How frequently are you getting the ESR and the PIK3 mutations done in the ERPR positive patients right in the beginning?
PIK3CA, yes. ESR1 not yet done up to now. PIK3CA also, not 20-30% patients is what we are able to convince, but we are doing PIK3CA once the patient has progressed on a CDK4/6.
Okay, not before that, not at the time of initiation of the hormonal treatment. So then, how important is it to delay the chemotherapy, which is achieved by the abemaciclib for the healthcare, both for the doctors as well as for the patients in these hormone-positive metastatic breast cancers?
So we're very true, sir. The whole quality of life can be preserved if you can delay chemotherapy to third or fourth line. For an endocrine positive patient who has sort of a low-grade disease, which is endocrine sensitive, the first, second, and third line should be more of an endocrine therapy and reserve chemotherapy to as late as possible, or in case of a visual crisis.
Yeah.
So delaying initiation of chemotherapy is a important endpoint in terms of maintaining a good quality of life in these patients.
That's right. So I think we've seen in the patients of the early breast cancers, in the patients with the locally advanced breast cancers, in the metastatic breast cancers who are hormone positive. So nowadays there is a hesitancy to use the chemotherapy even in the adjuvant setting for the patients, and then that's why we go for the gene recurrence score. And similarly, in the metastatic breast cancers, it's very important to delay the chemotherapy as much as possible. So we could use the first line, second line, and so on, and to go to the chemotherapy. end only when the response is not possible. So I think we should be aware of the quality of life issues in these patients, especially in the postmenopausal. So that's important to maintain the quality of life and delay the chemotherapy as much as possible. Yes. So can we have the next slide, please? So with the liver metastasis, I mean, with the choice of the CDK4/6 inhibitor that we have, so and you have shown, I think, Dr. Chandrakant, you've shown a patient also with the liver metastasis, and which one do you think is the most effective CDK4/6 there?
Well, sir, it's a tricky question because we do not have a head-to-head comparison among the CDK4/6 inhibitors. But if you look into this specific subset of liver mets, this has been quite well answered in the Monarch 2 and Monarch 3 trials, and the hazard ratio is in 0.4. I think that's quite impressive. If you have a liver mets and you have a hazard ratio of 0.4, in contrast to a hazard ratio of 0.5 with the overall disease, I think if you have a liver mets, which is a difficult to treat disease, the delta of benefit with abemaciclib is quite impressive. So definitely in this difficult to subgroup population, especially liver mets, you have impressive hazard ratios, and that was the reason why I did offer abemaciclib to the subset of patients.
Right. So the rapidity of response is also very good, and with the visceral metastasis, the responses are good. That's
yes.
So though other ones, it doesn't mean that the others are ineffective.
Yes, yes.
Than others, right? Okay. Next one, please. Yeah. So does the endocrine resistance status of the patient impact on your use of the abemaciclib?
So yes, sir, I think very important, we have primary, secondary endocrine resistance. If you look into the primary endocrine resistance subset, especially, primary endocrine resistance is where we have seen the Paloma trial did not show overall survival benefit. So whereas if you look into primary endocrine resistance in the Monarch trial, you have survival benefit. So this subset is where the hazard ratio is again very impressive. The delta is much better. So again, this is another subgroup where I would choose abemaciclib over the other existing CDK4/6 inhibitors, because this particular subset has been specifically answered in the Monarch group of trials.
I can see Dr. Vikas has joined us. Is your audio okay, Dr. Vikas, now?
I'm fine, sir. Thank you. There was a network. I'm very sorry for that.
That's not a problem. So we missed you there. So maybe you could take on this question, endocrine resistance status. So supposing the patient is there with a de novo metastasis, or the patient who's had a recurrence later in the endocrine sensitive, which one do you think is going to respond? Are they going to respond? Both of them going to respond well? Is there any change in the abemaciclib approach there?
So I presented just before the data for the ESR1 mutations, and we know that the ESR mutations are some mutations which we acquire, and that's where the endocrine resistance do play a very important factor. Endocrine resistance, as we know, our traditional therapies do tend to fail, and that's one of the worst prognostic groups to treat with. The ESR1 mutations, the PIK3CA mutations, that's where during the course of your treatment, the incidence of these mutations tends to increase. And that's where in the worst groups, you have a very good data for the abemaciclib and the fulvestrant combinations based on the exploratory analysis of the Monarch 2 study. So now we have a very good data for it, and that's where we need to reconfirm that, yes, this drug is something which is biologically different from the other entities. And yes, it has shown its efficacy, especially in those groups which are performing worse than their counterparts in the subgroups, especially those with endocrine resistance. Because these patients do tend to have a higher incidence of the corresponding ESR1 mutations and the PIK3CA mutations, and that's where abemaciclib outscores over the other agents at the same point.
Right. Thank you. I think how much time do we have more? Can we have the next slide, Dr. Chandrakant?
Just 5 minutes.
Oh, yeah, still we're quite fine there. So importance of the continuous dosing in your practice, and does it influence your treatment decision? Dr. Vikas, we've been missing you, so maybe you could take on this question. So
I love this drug because at the end of the day, these patients come from a very, very far outreach area. So to explain them the 3 weeks on and 1 week off schedule is also tiring, as whether they would have taken that third week last dose or not. And also, so logistic wise, the continuous dosing is very important. Biologically wise, I am always of the pro opinion that why that 1 week off? It's not a standard chemotherapies. We are giving them a time to recover, because as we know, the cancer doesn't take a day off, and that's where it is important to continue this dose schedule throughout the course of the treatment. And that's where the continuous inhibition, because probably the 1 week off leads to selection of the resistance clones during the biology. We don't know the biological cell, but yes, definitely the continuous dosing is something which does impact the treatment outcomes, and it is much more logistically also, and also biologically also. And that's why my treatment decision tends to be biased towards the continuous dosing in my practice, as compared to the 3 weeks on, 1 week off of the other CDK4/6 inhibitors that we have in our portfolios for now.
Right, thank you. Dr. Chandrakant, any further additions to what Dr. Vikas has said?
No, that's perfect, sir. I think, we are giving 3 weeks on, 1 week off because of the dose limiting toxicity of cytopenia. So if there was no cytopenia, we would have given the other two as well continuously. So therefore, it's more of managing toxicity rather than efficacy. So if you have the privilege of giving continuous dosing, that's the way to go, and that's what we do with abemaciclib.
Yeah, fine. So in fact, my practice is also, in my opinion, is also the same. Continuous doing much better. Just keep taking the things and then send your test once in a while, rather than having the 3 weekly on and then 1 week off, check your accounts and then restart. So there is always a consultation on the telephone, sending a message. Should I start? Should I start? I mean, actually, that's been a little troublesome kind of a practice, and this continued dosing is really very convenient. Takes away some kind of a stress from our things. Next slide. Can we have the next slide? Or that's all. Yes. So the okay. So that's abemaciclib and the diarrhea. So what has been your experience, Dr. Chandrakant? I heard you're saying about in your patient the incidence is less, and what about in other patients?
So the intestinal flora of Indian population is different from the Western population. So diarrhea is not that concerning in our population, even though we do see in quite a good number of patients, but not to the extent of what is reported in the MONARCH trials. So diarrhea is not yet concerning, and it usually settles with anti-motility drugs. So if you do probably a real-world study in India, you will not find diarrhea to the extent of what has been reported in the MONARCH trials. So it's different in our setting.
Yeah, Dr. Vikas, your experience?
Totally agree with Dr. Chandrakant, sir, because what the incidence of diarrhea has been portrayed in the Western world is because of probably the 200 milligram twice daily schedule, and most of us are convenient with the 150 milligram twice daily schedule, and that's where there is a discrepancy between 30% of it. Most of us have been familiar with many burst agents like capecitabine, sorafenib, in other agents also, in other indications also, and we know how to manage these diarrheas, and that's where we are in more pro of prescribing anti-motility agents at the first go, and also in the prophylaxis, and that's why the diarrhea is not something which is more clinically significant to me, because I know the diarrhea is going to be managed by the local physicians also. Even if they have some incidents of diarrhea, they are going to report to the local physician, and they're going to give some agents for it that's going to get immediately disappeared. The cytopenias, on the other hand, is something which the local physicians tends to put their hands away, and then it becomes difficult because sometimes they might change into febrile neutropenias. But then again, that's a different thing to say. But then diarrhea is something which will never resist me for prescribing abemaciclib in my future practitioners.
I request you to conclude your
we
discussion in 1 minute.
Next slide. Do we have another one? So how involved are the patients in your choice of the CDK4, Dr. Chandrakant?
I think treating any patient in the present day is a shared decision where we explain the pros and cons to the patient, including the toxicity, cost, duration, efficacy, everything. So if you can explain these, definitely patient involvement is an important component of decision in practice.
Yeah. Right. So, all right, I think that should be the end of the questions. And thank you very much, organizers. Thank you very much, Eli Lilly. Thank you very much, Dr. Chandrakant and Dr. Vikas, for your wonderful comments and participation. And if in the end, if there are any questions, any suggestions from the audience, we could have in the next 1 minute. And if there are none, over to the organizers, please.
Thank you, sir. Thank you, Rangarao, sir. And next we move on to the next session.
Thank you. Thank you very much.
And for this, I would like to invite Dr. Krishna Prasad, who is Senior Medical Oncologist, Institute of Mangalore, and he's going to talk on redefining the management of HER2-negative early breast cancer. Over to you, sir.
Yeah, thank you. Thanks to the organizers. Is my slide visible?
Yes, sir. You need to make it a full screen.
Yeah. So the talk is on redefining the management of HER2-negative early breast cancer. So this would be the flow of the talk: background, role of testing BRCA mutation, targeting this mutation in early breast cancer, and a short summary. So we know that early breast cancer is not very common in India compared to the Western countries. It's around 30%, and around 57% of our patients have loco-regional disease. Now, the general treatment of early breast cancer has been discussed a lot, but suffice to say that the whole discussion now on is only on HER2-negative breast cancer. That is, either it is ER/PR positive or it is triple-negative breast cancer. So if you look at these patients of breast cancer, say if you take 100 cases of breast cancer, you will find that a few of them will be triple negative, majority of them will be ER/PR positive, and a small number will be HER2 positive as well. Now, if you look at patients with HER2 positive, the chances of having a germline BRCA mutation is extremely rare. This is much more common in a triple negative disease, but the sheer population of an ER/PR positive disease makes it the type of malignancy common to have a BRCA mutation. So it's just because of the sheer number of patients of ER/PR positive disease. The approximate 5 to 35% of breast cancer patients harbor the mutation, depending on what kind of patients you see. So patients with this BRCA mutation have a distinct aggressive phenotype. So more likely to occur in a younger age group, more likely to be higher grade, more likely to have brain metastasis, as well as contralateral disease. These mutations, the exact incidence is not very clear. An analysis by Arun Sheshachalam, Krishna Ratnam, and others suggested that in around 59 patients of triple negative breast cancer, the incidence was around 14%. There is also data to suggest that not all our patients actually get the test done, which is absolutely the thing which happens with all our clinical practice. However, in early breast cancer, upfront knowledge of this mutational status might help us to plan our surgery as well as targeted therapy better. So this is where the Olympia trial has come into the picture. Now, this is a landmark phase 3 study of olaparib versus placebo as adjuvant treatment for high-risk patients with germline BRCA mutated HER2 negative breast cancer. So to be eligible for this trial, patients should have germline BRCA1 or BRCA2 mutation, stage 2 or stage 3 breast cancer. They should be HER2 negative. They should have completed local treatment and chemotherapy, which should be at least anthracyclines or taxanes, but most of the patients would get both the ones. Now, I will just look into more detail about what are the type of patients which went into the trial. So which are these high-risk patients according to the Olympia trial? So the patients were either triple negative breast cancer or hormone receptor positive breast cancer. You can see that majority of them, that is 82% of the patients, had triple negative breast cancer. Now, in triple negative breast cancers, it could have been taken of patients who had undergone neoadjuvant therapy or adjuvant therapy. If you are taking patients who have got adjuvant chemotherapy, this patient should have had a node positive disease or a disease which is at least 2 centimeters in size. So basically a T2 disease or an N1 disease qualifies as a high risk in a triple negative patient. Now, if this patient had received neoadjuvant chemotherapy, patient should have residual disease at the end of chemotherapy. That means patient should not have achieved a pathological CR. Now, if you take hormone receptor positive breast cancer, obviously the criteria is little more stringent, because if patients had received adjuvant chemotherapy, they should have had at least 4 pathological confirmed lymph nodes, whereas in triple negative disease, any positive lymph nodes would take it up for eligible patients. Whereas if patients had received neoadjuvant chemotherapy, they should not have had a PCR, and also their CPS plus EG score should be minimum 3. Now, what is this CPS EG score? It is a clinico-pathological staging, estrogen receptor status, and the grade of the disease. So totally, if you look at this table, you can see that the maximum score can be 6 and the minimum can be 0. And over a period of time, if this score was more than 3, then these patients were taken as bad prognostic signs. So why did this happen is because multiple trials did show that patients with HR positive and HER2 negative disease seem to have a progressively worse prognosis if this scoring system had a higher score. Because of this, this criteria was taken. Now, what did they do with these patients? They randomized in 1:1 fashion to olaparib, 300 mg BD or placebo. And this treatment duration was for 1 year. The primary endpoint was invasive disease-free survival. There are a host of secondary endpoints, including distant disease-free survival, overall survival, any BRCA1 and 2 associated cancer, the quality of life, and of course, the safety and tolerability. Now, if you look at the baseline characteristics, more or less very well matched, you can see that the age of the patients in generally is less. That is what we know about BRCA mutated cancers. The average age is 42 years. Most of them had BRCA1 mutated. That is how we see it in the population. Around 70% had BRCA1 mutation. 2/3 of them were premenopausal. Now, if you look at the other baseline characteristics, 50% of them got an adjuvant treatment, whereas 50% of them received neoadjuvant chemotherapy. Most of them, that is around 90 to 95% of them, received both anthracyclines and taxanes. It was a very small number which received taxane alone or anthracycline alone. Around 2/3 of them did not receive platinum agents, and around 25% of them did receive carboplatin or cisplatin. Most of the patients, like I already mentioned, around 82% of them were triple negative breast cancer, and the percentage of patients with HR positive was only around 18%. Patients who had hormone receptive breast cancer, most of them nearly received concurrent hormonal therapy. Now, what is the result? The primary endpoint, that the invasive disease-free survival, the first data cutoff point was at 3 years. And at the 3-year invasive disease-free survival rate, difference was between 77% and 85.9%, with the delta being 8.8 and hazard ratio being 0.58. And this benefit seems to be persisting with an extra year of follow-up. That is, at 4-year IDFS rate improved from 75% to 82%, again with a delta of around 7 and a hazard ratio of 0.6, suggesting that the invasive disease-free survival benefit seems to be persisting with the second data cutoff point also. What about patients with the secondary endpoint of distant disease-free survival? Here again, you can see that at the 3-year distant disease-free survival difference was around 7% with a hazard ratio of 0.57. And just like the invasive disease-free survival difference, Even the distant disease-free survival difference continued even at the end of 4 years, where the second data cutoff point was analyzed. What about the overall survival? At the first point of data analysis, there was no statistically significant overall survival difference. But when the second data cutoff point was analyzed at 4 years, you can see that the overall survival difference was around 3.4% with a hazard ratio of 0.68. It is absolutely rare for us to get an overall survival benefit in any clinical trial in the adjuvant breast cancer setting. What about second primary non-breast cancers? Because we are all worried about second cancers when you treat them with PARP inhibitors. You can see that the incidence of second primary non-breast cancer was less than half compared to patients who received placebo. And also the chance of CNS recurrence was significantly different when patients received olaparib. Now, when you look at the subset analysis, whether patient received adjuvant or neoadjuvant treatment, platinum or no platinum, whether they were TNBC or HR positive, whether BRCA1 or BRCA2 positive, in all the subgroups, there was a significant benefit in terms of the primary endpoint, which is the invasive disease-free survival. And this benefit seemed to be persisting with the secondary endpoint of distant disease-free survival and also importantly, overall survival, suggesting that in all subgroups, there is benefit with using olaparib in the adjuvant setting. Now, how was the tolerance? How many people completed the trial? At least 70% of patients completed 1 year of olaparib. How many required dose reduction? 25, less than 25%. So 75% of them completed without any dose reduction. Around 18% required 1 dose reduction, and around 6 to 7% required more than 1 dose reduction. Now, why was this dose reduced? Most of the time for adverse event, and the commonest being anemia. So how many patients actually discontinued treatment due to adverse event? Around 10%. And the commonest reason for discontinuation was anemia and nausea. Now, most of the adverse events were mild to moderate. In fact, the most dangerous adverse event of MDS bar acute myeloid leukemia was numerically actually less in the olaparib compared to the placebo arm. So if you look at the adverse events which were seen, it was consistent with all the other trials where olaparib was used, with nausea being the commonest adverse effect, followed by fatigue. But the commonest grade 3 adverse effect was anemia. In fact, that was only one which occurred more than 5% of the patients as a grade 3 toxicity. How many people required blood transfusions? Not many. Majority of them required only 1 blood transfusions, and there were very few percentage, around 1%, who actually received more than 1 transfusions. What about the global health status quality of life score? There was absolutely no difference among patients who received olaparib compared to placebo, suggesting a good tolerability as well as quality of life. This was irrespective of whether you gave him adjuvant chemotherapy or neoadjuvant chemotherapy. Now, when all this olaparib trial has been going on, there are a host of other trials which has come in this setting. Already mentioned Keynote 522 by Dr. Vikas, where he showed clearly that adding pembrolizumab to chemotherapy significantly improves the event-free survival. IMpassion 031 again improved the PCR rate. The Monarch E improved the invasive disease-free survival. Note that all these 3 trials did not, or at least have not, reported an overall survival benefit. What about the Pallas and Penelope trial? I won't go into it because they are negative trials. The only trial here which actually had an overall survival benefit was the CREATE-X trial, wherein it showed that adjuvant capecitabine had an overall survival benefit of roughly around 5.5%. Also, if you look at the older trials as well as many other trials, including in the HER2 setting, the only 2 drugs which have really shown overall survival benefit, apart from, of course, using hormonal therapy, were trastuzumab and olaparib. So it is not very common for us to get overall survival benefit statistically significant. Now, with all these background, how do you really manage patients who are HER2 negative, high risk breast cancer? So in these patients, let us take triple negative breast cancer. If they are BRCA wild type, of course, you would think about giving them adjuvant capecitabine if they have residual disease and they are high risk. Also, you would think
Sir,
about
would request
using,
you to conclude your presentation in 2 minutes.
this is the last
Thank
slide. So adjuvant pembrolizumab, if pembrolizumab actually had been given preoperatively, and in patients who are BRCA mutated, probably it would be worthwhile to use olaparib for 1 year. Now, what do you do if patient, you're thinking about capecitabine also? If you look at both these drugs, probably in patients where BRCA is positive, olaparib might be a better drug. Of course, in the adjuvant setting, there is no head-to-head comparison. But if you look at in advanced disease setting, in patients who are BRCA mutated, olaparib might have the edge over capecitabine. Among patients who are hormone receptor positive, patients, if they are BRCA wild type, of course, you can think about abemaciclib. If they are BRCA mutated, how do you choose abema versus olaparib? Probably you would think that olaparib has shown overall survival benefit, whereas abema still has not, and you would probably pick olaparib. So to conclude, the Olympia trial probably is the landmark trial where it showed clear clinical benefits of using olaparib as adjuvant therapy in high-risk HER2 negative early breast cancer. 1 year adjuvant olaparib significantly reduces the risk of recurrence and death. It results in patients living longer and at least nearly 3.5% more chances of being alive at 4 years compared to placebo. It is quite a safe drug. And probably we need to start testing BRCA for BRCA mutation upfront in patients who are TNBC as well as in patients who are hormone receptor positive. Thank you.
Thank you, sir. Thank you for the excellent presentation. And next we move on to the next session on ESMO Updates 2022. And for this, I would like to invite Dr. Srujana Joga, who is Consultant Medical Oncology at prestigious Rajiv Gandhi Cancer Institute, Delhi, for her abstract presentation. And ma'am, you have 7 minutes to present your abstract. Over to you, ma'am.
Yeah. Thank you, organizers, for giving me this opportunity to present in this meeting the ESMO updates. So,
Should I share from my side?
yeah, just. So
Yes,
are
ma'am,
my
the
slides moving?
Yes, visible. They are not
Moving?
moving. Ma'am,
Not
you make
moving?
it a full screen. Just make it full screen.
Yeah, I made it full screen.
It's not seen to be.
Just to give you-
So, ma'am, we will share it from our end. Ankit, please do
yes.
the needful.
Okay, you can share.
Yeah, sure, ma'am. Yes, ma'am. Go ahead.
Good evening, everyone. So I'll be presenting the mutational signature analysis, which reveal the patterns of genomic instability, linking the resistance mechanisms to the endocrine therapy with or without CDK4/6 inhibitors and the hormone positive HER2 negative metastatic breast cancer setting. Next slide. So this was presented at the ESMO Paris 2022 by Antonia Mara. Next slide, please. So to begin with, the breast cancers have complex genomes and there are a variety of mutations, out of which there are only finite number of drivers which we know of as of today, mainly the PIK3CA mutations, the cyclin D1, MEK mutations, HER2, BRCA1 and TP53. To the right side of the slide, we see that there are the mutation process is actually not just doesn't happen once. It happens throughout the life, starting from the process at the time of the birth. It accumulates with occupational exposures, and intermittent bursts occur with repeated environmental exposures. And there are a lot of mutations occurring with acquired DNA repair defects, together resulting in a complex set of mutations, ultimately leading to the cancer. Next slide, please. So analyzing these mutational signatures is important. Both it has got a prognostic and a predictive value. As we can see in this slide, if the patient has signatures of that of MMR deficiency, they have this MLH1, MSH2, MSH6, and PMS2 set of genes deficiency, and we have a target for that, that is a checkpoint inhibitors anti-PD-1 monotherapy. Whereas in patients with small cell lung cancers, they have a typical smoking signatures with BAP adducts on guanine, for which there is no therapeutic target. And on the third one is the homologous recombinant deficiency with the BRCA1, 2, PALB2, and a lot of other enzymes like ATM. We have a target with PARP inhibitors, and they are mostly platinum sensitive. And today we'll be mostly talking about this ApoBec mutations, which are most commonly seen in breast cancer, bladder, and head and neck cancers. These ApoBec enzymes activity help in progression of the cancers. So they are of clinical significance. And the others like clock-like mutations. Next slide, please. So the ApoBec mutations, their basis is yet to be fully determined, but all we know as of today is that ApoBec is important whenever there is a mutation. The cytidine base is converted into a uracil by the process of deamination. So this is mostly commonly seen in the hormone-positive, HER2-negative breast cancers, and a little less in the triple-negative breast cancers. Next slide, please. So this study addressed the questions of the which pathological and clinical features are associated with the ApoBec enriched signatures or other mutational signatures, and do these ApoBec and mutations have a clinical benefit to the standard treatments, and what are the genomic alterations which have been enriched in ApoBec mutated breast cancers. Next slide, please. So for this, they took a MSK impact tumor normal clinical cohort of around 4,500 breast cancers, and they analyzed the clinical and pathological factors through an AI machine, and they derived a clinical genomic analysis out of that. Next slide, please. So this slides depicts what the challenges we have in detecting these mutation signatures, because in whole genome sequencing, we get around 4,500 substitutions. When we narrow it down to exome sequencing, we just get around 50 substitutions. But when we do a targeted panel sequencing, we just get information about a one gene or a one substitution. So important is that the mutational signatures will be more accurate to be picked up when we do it on whole genome sequencing. Next slide, please. So they used a machine learning based mechanism for deriving the mutational signatures. Next slide, please. So they the MSK impact targeted gene panel consisted of more than 400 genes, and they analyzed for the somatic mutations and the copy number alterations. And they derived a sigma algorithm for samples having at least 5 single nucleotide variations. So the exposure here is defined as the fraction of mutations, that is the percentage of mutations associated with a given mutation signature. And the dominant signature is the top mutational signature assessed by this machine per sample. Next slide, please. So in this slide, we see that the hormone positive HER2 negative breast cancers have the higher ApoBec and HRD deficient signatures, whereas it's the same whether it be HER2 positive or HER2 negative. Whereas in the TNBC setting, the ApoBec signatures are a little lesser, and the HRD mutation signatures are higher, be it the primary or the metastatic setting. Next slide, please. So when they took a analysis of the primary and the metastatic paired samples, the APOBEC mutations have increased in frequency. That is 17% to 25% when the tumor has metastasized. So the frequency of APOBEC mutations has increased in the advanced breast cancers. The same is with the CLOP mutations. Next slide, please.
Ma'am, request you to conclude your presentation in
Okay,
1
so the
minute.
breast cancers with APOBEC mutations, the pathological features are linked to the lobular phenotype, and those with tumor mutation burden more than 10. And this is associated with hormone positive breast cancers, and in the TNBCs, HRD are the most important subset. Next slide, please. So the predictive significance, the APOBEC and HRD are associated with the endocrine resistance. So when only endocrine monotherapy without CDK4/6 inhibitors was analyzed, the PFS was worse, that is around 9 months, with a APOBEC mutation signature breast cancers. Next slide, please. Whereas patients who have received endocrine therapy plus CDK4/6 inhibitor, the HRD did the worst with 7.6 months of median PFS. Next slide, please. So the APOBEC dominant breast cancers, the specific genomic alterations associated are the NF1, ARID1A, and the PTEN mutations, along with the KMT2C. Next slide, please. So the gene enrichment analysis for samples with dominant APOBEC revealed that the primary and the metastatic, there is difference in the mutations, with PIK3CA mutations being most frequent in the hormone positive setting, whereas in the triple negative setting also, the APOBEC signature has shown CDH1 mutations and the PIK3CA mutations also. Next slide, please. And that too, with the PIK3CA helical mutations are enriched in the APOBEC high breast cancers, and double PIK3CA mutant breast cancers, as seen in the green bar to the right, have a higher frequency of APOBEC mutations. Next slide, please. So to conclude, the hormone positive, HER2 negative breast cancers acquire the genomic instability, with the APOBEC and HRD being the main drivers. And the cancers with the APOBEC mutagenesis are having a higher tumor mutation burden and associated with lobular cancers, and specific PIK3C mutations and CDH1, NF1, and PTEN are associated with it. So the APOBEC dominant hormone positive metastatic breast cancers have worst PFS when given endocrine therapy alone, whereas the HRD dominant hormone positive metastatic breast cancer have shorter PFS when CDK4/6 inhibitors is combined with the other endocrine therapies. Thank you.
Thank you, ma'am. Thank you, ma'am, for the excellent presentation. Next, I would like to invite Dr. Srinivas KG, who is Senior Consultant Medical Oncologist at CG Mysore, for the next abstract presentation.
Shall I share my screen?
Yes, sir.
Can all of you see the slides?
Yes, sir.
Slide is moving?
Yes, sir.
Okay. I thank the organizer, Dr. Rahul Sood, for giving me this opportunity to talk on this topic 2. So it's the primary results from topics 2, a randomized phase 3 study of sacituzumab govitecan versus treatment of physician's choice in patients with HR positive, HER2 negative advanced breast cancer. Breast cancer is the second leading cause of cancer deaths in women. HR positive, HER2 negative is the most common subset, accounting for 70% of breast cancer. Sequential endocrine therapy combined with targeted agents is the recommended option for metastatic HR positive, HER2 negative breast cancer. The international guidelines recommend first-line endocrine therapy in combination with CDK4/6 inhibitors. The optimal sequencing of therapeutic agents following progression on ET plus CDK4/6 remains unclear. And we all see that once they progress on a particular CDK4/6 inhibitor, we all struggle what next to be offered to these patients. For endocrine therapy resistant disease, sequential single agent chemotherapy is a standard of care. However, it's associated with declining response rates and disease control and quality of life and increased toxicity. There are very few chemotherapy options are available in later lines, and there remains a high unmet clinical need. TROPiCS-02 is a phase 3 study evaluating sacituzumab govitecan therapy for heavily pretreated patients with HR positive HER2 negative metastatic disease who have received prior endocrine therapy and as well CDK4/6 inhibitor and also prior multiple lines of chemotherapy. So TROP2, a transmembrane calcium signal transducer linked to tumor progression and poor prognosis, as we all know, is highly expressed in approximately 80% of breast cancers, regardless of the subtype. And SG is approved for patients with metastatic TNBC with more than 2 prior therapies or more than 1 in the metastatic setting. There are phase 1-2 studies, phase 2 studies, which showed sacituzumab govitecan which having a encouraging clinical activity in patients with previously treated metastatic HR positive HER2 negative breast cancer, with a pretty overall response rate to the tune of 32% and the median PFS by investigator assessment around 5.5 months. So SG is a first-in-class TROP2 directed antibody drug conjugate. As you can see on the right side, a linker for SN38, and we know that SN38 is a potent or more potent than a parent compound of irinotecan, which is linked with humanized anti-TROP2 antibody. So once it is internalized, there is an enzymatic cleavage by tumor cells, which not required for SN38 liberation from antibody. So TROPiCS to a phase 3 study of SG in HR positive HER2 negative locally or recurrent inoperable or metastatic breast cancer. So patients who are metastatic or locally recurrent inoperable HR positive HER2 negative breast cancer that progress after at least 1 endocrine therapy, a taxane, a CDK4/6 inhibitor in any setting, at least 2 but not more than 4 lines of chemotherapy for metastatic disease. So we can understand that patients will be typically very heavily pretreated patients in this population, and a measurable disease by RECIST 1.1, which is randomized to 1:1 fashion. In one arm, sacituzumab govitecan 10 mg per kg IV, day 1 and day 8 every 21-day cycle, and on the other arm, treatment of physician choice, including capecitabine, vinorelbine, gemcitabine, eribulin, which we all practice on day-to-day practice. The endpoints are: primary endpoint is PFS by BICR, and the second endpoint, like OS, overall response rate, PRO, and safety. And the stratifications include visceral metastasis, endocrine therapy in metastatic setting for more than 6 months, and prior lines of chemotherapy. So this is a statistical analysis, and this is a patient disposition. Around 776 patients were screened, and 543 patients were randomized. And in the SG arm, it was around 272 patients, and treatment of physician choice is around 271, which was very well balanced in both the arms. And at the end of the study, still 18 patients were remaining still on treatment with sacituzumab govitecan, and only 4 in treatment of physician choice arm. These are basic baseline characteristics and demographics, which were very well balanced for both the arms. And these are the prior therapies like neoadjuvant, adjuvant, and if it is metastatic, how many prior lines of therapies. And the primary endpoint was BICR assessed PFS as per RECIST 1.1 in the intent to treat population. If you can see, SG demonstrated a statistical significant improvement in PFS versus treatments of physician choice, with a 34% reduction in the risk of disease or progression or death. A higher proportion of patients were alive and progression free at all landmark time points, like at 6 months, 9 months, and 12 months. So if you see the median PFS of 5.5 months versus 4.4 months was seen for the hazard ratio of 0.6x. And if you see the 6 months PFS rate, 46.1% was observed in SG arm compared to 30.3 in TP's treatment of physician choice arm. And if you see 12-month PFS rate, still 21.3% had progression-free survival, and compared to 7% in treatment of physician choice arm.
So request you to conclude in 1 minute.
Yeah, I'm done. This is a forest plot analysis showing all the subgroups get the benefit of sacituzumab govitecan arm, like ECOG and age across the, whether it is less than 65 or more than 65, prior CDK4/6 inhibitor usage, and visceral metastasis. If you see the OS, it is still not yet mature at the first of 3 planned OS analysis and requires further follow-up. So the overall response rate was pretty impressive, 21% versus 14%, and combined response 34% versus 22%. And overall, the safety profile of SG in this study was consistent with that observed in previous studies of SG. So in conclusion, and I just want to highlight one more, even in the quality of life was better according to the TTD in global health status and the fatigue scale as well. You can see the SG arm did better. So to conclude, in patients with heavily pretreated HR positive HER2 negative advanced breast cancer who have received prior endocrine-based therapy, including CDK4/6 inhibitor and at least 2 prior chemotherapy regimes for metastatic disease, SG demonstrated a statistically significant PFS benefit over treatment of physician choice. The primary endpoint of PFS by BACR was met with a 34% reduction in risk of disease progression or death, for the hazard ratio of 0.66 was observed. A higher proportion of patients were alive and progression-free at all landmark time points, with 3 times as many patients progression-free at the 1-year mark when treated with SG compared to those who received treatment of physician choice. At the first planned interim analysis of OS, a numerical trend for improvement for SG was observed, but the results are not yet mature. Overall, the SG demonstrated statistically significant clinical meaningful benefit and should be considered a potential treatment option in this heavily pretreated patient population with limited treatment options. Thank you.
Thank you, sir. Thank you so much for finishing rightly in 7 minutes. Thank you for the excellent presentation. Now, to present the next abstract, I would like to call upon Dr. Kanika Sharma, who is consultant medical oncologist, Max Hospital, Mohali. Over to you, ma'am.
Yeah. Hi, good evening, everyone. Okay. So are my slides visible?
Yes, ma'am.
Yeah. So good evening, and thank you for including me in the part of these series. So I will be discussing this METEORA-2 trial that was presented in the recently conducted ESMO Congress 2022. So it's a randomized phase 2 trial of the metronomic oral vinorelbine plus cyclophosphamide and capecitabine, that is the VEX regimen, versus weekly paclitaxel, that is routinely used as the first line or second line treatment in patients with hormone positive and HER2 negative metastatic breast cancer. So this trial was designed with the concept of the metronomic VEX regimen to administer to the metastatic breast cancer patient for as long as the patient have the possibility of deriving a benefit from it. So this regimen was compared with weekly paclitaxel in patients, and the primary endpoint was the time to treatment failure, which was chemotherapy start of the treatment to the chemotherapy stopped due to lack of tolerance, lack of efficacy, or because of the patient preference. So the inclusion criteria in this trial was histologically or cytologically confirmed ER positive, HER2 negative, locally advanced or metastatic breast cancer. There should be a measurable or non-measurable disease, but radiologically evaluable disease should be present. Female more than 18 years of age with a ECOG performance status of 0 or 1. The patient should have not received more than 1 line of chemotherapy for advanced or metastatic breast cancer and not more than 2 lines of previous endocrine therapy, including a CDK4/6 inhibitor. So the patients were randomized into 1:1 order into paclitaxel 90 mg per meter square on day 1, 8, and 15 every 4 weekly versus the VEX regimen, which included the vinorelbine 40 mg orally on day 1, 3, and 5 every week, cyclophosphamide 50 mg to continue daily, and capecitabine 500 mg thrice daily to continue. The patients who have received taxanes in the neoadjuvant or adjuvant settings, they should have a gap of minimum 12 months between the adjuvant setting and the restart of the paclitaxel. The patient who already have a peripheral neuropathy of grade 2 or higher were excluded, and also patients with the active CNS metastasis were not included in this trial. So the secondary endpoints were progression-free survival, overall survival, and the disease control rate. So from September 2017 to January 21, around 140 patients were randomized at 15 centers in Italy, and 133 patients, they initiated treatment, around 70 patients into the VEX regimen, and 63 patients in the paclitaxel arm. So this was a 4-weekly cycle, and 133 patients were entered the efficacy analysis population. So the chemotherapy could be delayed by a maximum of 3 weeks, and the time to treatment failure was defined from randomization until permanent discontinuation of the chemotherapy regimen for any reason. And out of this 123 time to treatment failure event, they have a 80% power to detect the hazard ratio of 0.6. So when we come to the result, in the 133 patients that were analyzed, they have a median age of around 61 years, ranging from 30 years to 80 years, with 21% of the patient having a performance status of 1, and 78% of the patient, they have a measurable disease. In total, 16% of the patient, they have received a prior chemotherapy for metastatic breast cancer, and 56%, more than half of the patient, they had only prior hormonal therapy, out of which 47% they have received a CDK4/6 inhibitor. So when we come to the adverse event, so 95.5% of the patient, that is 127 patient, they have at least one targeted adverse event, whereas 48 patient, that is 36.1% of the patient, they have at least one targeted grade 3 and above adverse reaction. So out of that 46% of the patient, the time to treatment failure was progression of disease, and 23% of the patient, the drug was continued because of the adverse event. And the adverse events, they were higher in the VEX regimen, that is grade 3 and more side effects. They were 42.9% in the VEX regimen as compared to 28.6% in the paclitaxel arm. And the grade 3 and 4, the most common observed adverse event was neutropenia. That was seen, even grade 4 neutropenia, that was seen in 9 patients in the VEX regimen and only 1 patient in the paclitaxel arm. And 3 patients, they died during the treatment. So when we come to the efficacy analysis, so time to treatment progression, which was the primary endpoint. So there was a significantly difference between the two arms, with the median time to treatment failure of 8.3 months in the VEX regimen as compared to 5.7 months in the paclitaxel arm, with a significant hazard ratio of 0.61. When there was a subgroup analysis was done with a patient who have received a prior CDK4/6 inhibitor, then also there was the difference was significant between the two regimen, with the VEX regimen having a time to treatment failure of 8.4 months as compared to a 5.6 months in the paclitaxel arm.
I request you to conclude your presentation in 1 minute.
Okay. So when we come to the progression-free survival, there was 11.1 month as compared to 6.9 month, but there was no difference in the overall survival between the two arms when it was seen. So the quality of life analysis was not done in this study. So METEORA-2 trial, they showed that the VEX regimen, they significantly improved time to treatment failure as compared to the paclitaxel regimen. And the VEX metronomic, it could be considered as a first-line chemotherapy regimen for patients with the hormone positive and HER2 negative metastatic breast cancer that requires chemotherapy. Thank you.
Thank you so much, ma'am. Thank you for the wonderful presentation. And I would request Rahul Sood, sir, for the closing remarks. Over to you, sir.
So we had a almost 3-hour plus session today. on the initial part of the breast cancer, that is the genomic profile, followed by the neoadjuvant, the role of immunotherapy in early breast cancer, the newer data that we get in early breast cancer, and followed by the adjuvant therapy. So a lot
Sir,
has been
sorry to
happening.
interrupt you, sir. Ma'am, can you please exit the slide? Kanika ma'am, thank you. Thank you, sir. Please.
Yeah. So we finished first part of the breast cancer, and I think it was a really good experience. I thank all the speakers, all the panelists for today's presentation, and also our scientific partners who are there as shown in the picture. So please do join us tomorrow once again at the same time, 6:30, as we discuss probably the most important part of breast cancer, that is the advanced and metastatic breast cancer. We'll also be discussing the latest from the ASCO, not just the abstracts, but what ASCO really told us this time, and the ESMO, and how together the Americans and the Europeans together for the very first time have come to a consensus in breast cancer management. So looking forward to seeing you tomorrow once again. Once again, thanks again to all the speakers, sponsors, and definitely to Horizon and Healthy Blossoms, under whom we are conducting this. And over to the organizers once again. Yeah.
Thank you. Thank you, everyone, for joining. And we would like to welcome you tomorrow also for this grand academic feast. Meet you tomorrow on the second day of the breast cancer management at the same time, 6:30 a.m. Good night.